that.
Can I do it quick? Thank you.
I think we're going to start.
It is 1 minute left.
We're going to keep this very accurate, pinpoint accuracy by the looks of it. Right. Well, first of all, I'd like to welcome everybody here. I honestly, I have to pinch my skin to believe that this has actually happened. This started in 2017 when I came to a conference in Kyiv, and I met Antonina. And Antonina, myself, and Alexandra, we had a discussion as to about whether McKeeDerm might lend itself towards a conference. And so we decided that we would have one. And to my astonishment, and I really am astonished, and I'm rather emotional that we've actually succeeded and we brought so many people here. So I'd like to say hello to everybody in the audience, and in particular to the audience members who are from McKeeDerm. And I'd also like to welcome the people who are streaming the conference. Now, some of our speakers were unfortunately not able to come for a variety of reasons. I hope they're streaming, but I want to say hello particularly to Dr. Carla Ceruto, to Dr. Bipin Thingujam, and to Dr. Marcella Lima Saeb. Now, very, very briefly, I'll just get my pointer very, very briefly. In May 2017, I got a lot of encouragement from Jared Gardner, who's going to be lecturing at the conference, and I think he decided that I ought to come out of retirement and start a new career. So I took his advice, and we set up McKeeDerm, and on day one we had 6 members. There was myself, and I invited five friends. And I didn't check last night, but that was, I've forgotten whatever date, that's May the 14th. We'd gone from six members to 12,287 members, and we just continue to grow. It's rather like Topsy, if you know the analogy. Anyway, that's enough of me. So welcome to you all, and I'm now going to have a great pleasure in introducing Antonina, she's a fascinating woman. She's an extremely good dermatopathologist, but she has a secret. And her secret is she's actually a mathematician. Although she confessed yesterday that she can't actually add up. So if you ask her what 2 and 2 equals, you might get 4, but you might get 5 instead. But she's very good on theoretical mathematics, and she combines her expertise with her dermatopathology. And when I first met her, I thought, wow, she really knows what she's doing. And 3 years later, she's become an extremely good diagnostic dermatopathologist and a force to be reckoned with. Now, in 1948, which is a great year because that was the year I was born, there was a lady with the name Sophie Spitz. She wrote a seminal paper on juvenile melanoma. Now, the beauty of that paper was that pathologists were able, when they looked at melanomas in children, they could call them all Spitz nevus. And so life became very simple. Every time you saw what you thought was a melanoma in a child, you say, oh no, it's not a melanoma, it's a Spitz nevus because Sophie Spitz said it is. And life was very simple, and for the next 20 years we had a very pleasant existence with melanocytic lesions in children. And then, unfortunately, trouble set in and people started to try to reverse what Sophie Spitz had said, and the issue has become more complicated and more difficult. So I'm hoping that Antonina is going to educate all of you and me so that I have a better understanding of what I'm saying when I give my emphatic comments about Spitz nevi. So I welcome Antonina Kalmykova.
Thank you.
And I also want to say a few words. I really want to thank all of you for coming to Kyiv. It is just unbelievable to see all faces that I get used to seeing on Facebook page, like in real life. It is amazing. And I want to say thank you to Professor McKee, who actually keeps inspiring pathologists all around the globe, like doing more accurate diagnostic things. And actually my life changed dramatically when I met this person, because he became my friend, and I'm really happy that actually this event is starting and everything so great. When I only joined McKeeDerm group, I searching for help and experience, but found not only knowledge, but also really good friends. And I really thank you for that. Also, I want to say that I can imagine my life and my everyday practice before joining the group, when I said, let's discuss that on McKeeDerm group. And when I face something really difficult and share this case on the group, actually I know that that case will be discussed among the best professionals, and I get the best consultation. Also, I want to say thank you to our CEO of our laboratory, Alexander Dudin, who actually supports me from the very beginning, and he helped me a lot. And to our team, without whom it would be impossible to transfer our internet page to real life. And it's great, actually. I want to share with you one quote. Actually, who owns the information? This person owns the world, but who owns the information and friends lives at it happily. So I want to share with you my presentation about Spitz nevus. And actually, Philip already said that Sophie Spitz was the one who described a series of cases about juvenile melanoma. And she was the one who started to believe that neoplasms that looks very similar to adult melanoma behave differently in children. And she asked the questions about does the histological malignant melanoma of children differ in any structural details from that of adults? Can the clinical behavior of those lesions be predicted from their histological structure? What, if any, the factors known to influence the clinical behavior? Should the melanoma of children be treated by any different from melanoma of adults? And actually, these questions are still on time, are still asked by many pathologists all around the globe, and we try to find out what is the issue. Spitzoid melanocytic neoplasm are composed of large epithelioid of spindle cells, and they have a distinctive architecture. Now we know that it is not one tumor. Sophia Spitz probably described a heterogeneous group of tumors. And on the one spectrum of this tumor, we have a Spitz nevus. On the other side of this spectrum, we have a malignant spitzoid tumor. But what is between? There is a series of paper about atypical spitzoid tumors. But what is that? We try to find out. Clinical feature of spitzoid neoplasm actually quite distinctive. They occur in children or young adults. 2/3 of the cases occurs in under the 20, and 1/3 in older age. But actually now we see that we can see that tumor in people after the 40 years. It is a dome-shaped papules or nodules. Size vary from 2 millimeters to 2 centimeters with average diameter 8 millimeters. They are usually well circumscribed and vary in color. Surface also vary, and it is a huge variety of tumors depending on their surface. Maybe erosion on the top, maybe scale crust, and even ulceration. Maybe form due to sclerosis. Also, it is affect low extremities and head and neck region of young adults. Type of Spitz tumors actually quite distinctive. It is a conventional Spitz nevus. It can be disseminated, grouped, or pigmented spindle cell nevus of reed. Atypical Spitz tumor, and it is a question, does it category exist? Malignant or metastasizing Spitz tumor. Spitz nevus, it's a lesion that lacks atypical features and has a very low risk of neoplastic progression. As I said, there is a lot of different types of Spitz nevus, depending on their morphology, of architecture, depending on histological features, and so on. And I will show you the most prototypical ones. Actually, depending on the presence of melanocytes in the dermal-epidermal junction, in the derma, and both it can be divided on intraepidermal opigitoid tumor that actually affects extremities of young adults and mostly women. And this lesion is very beautiful because of evenly distributed melanocytes among the derma-epidermal junction. And pigitoid spreading we can see not only in the center of the lesion as we get used to see on Spitz tumor, but Spitz nevus, but also in the sides of it. And actually, pigitoid spreading of this tumor begins and ends with epidermal hyperplasia, and it is very important morphological clue to that diagnosis. Junctional Spitz nevus consist of large epithelioid nests of melanocytes, and they located on the dermal-epidermal junction. Actually, we all often see clefting between the derma and between the nests, and we often see a homogeneous basal membrane material that we know as camina bodies. compound nevus has melanocytes as in on dermal epidermal junction as well in the derma. It is very important to see a maturation. Maturation, it's a misnomer actually. It shows that melanocytes become smaller when we saw it in deeper part of the derma, but it still have epithelioid morphology. Also, it is very important, we can see mitotic figures in the upper part of the lesion, but not in the deeper aspects of it. And they quite symmetrical, they should be quite symmetrical. They distribute melanocytes very symmetrical. As you can see, there is no mitotic figures in it, and cells morphology and cytomorphology quite without any particular changes. It is not so striking morphology atypia. Intradermal nevus has melanocytes exclusively in the derma. And what features suggest in Spitz nevus? It's a young age, it is symmetrical and well circumscribed. We have to see a vertically orientated nest with a cleftin, central focal pidgetoid spreading if it is any, except of the case of pidgetoid Spitz, because in that lesion we often see a pidgetoid spreading among the whole lesion. Maturation of the dermal component, few or no dermal mitosis in the upper aspects of the lesion, and large epithelioid or spindle cells with little or no nuclear pleomorphism. Also, it is very important that this lesion has distinctive molecular features. And I want to highlight that it is quite often we see a tetraploidy in that lesion. That's why if we see typical mitotic figures, it doesn't mean that it is malignant. Sometimes it can happen, and it doesn't mean that it is a spitzoid melanoma. Malignant Spitz tumor, it's a variant of Spitz tumor with a very distinctive also histological features and genetic alteration. It is often non-symmetrical lesion with ulceration on the top or with a scale crust on the top. It shows no maturation and can affect deep aspect of the derma and even subcutis. Epidermal hyperplasia also can be uneven, and actually because of ulceration it has features of pseudocanceromatous hyperplasia. There are a lot of mitotic figures and so-called hot spots in this lesion, when we can see a lot of mitotic figures per one high power field. Features suggesting melanoma, it's age after 40, large size, asymmetry, irregular borders, depth of invasion. It can affect subcutis and even it shows no maturation. Nodular or sheet-like aggregates of melanocytes, diminished deep location of melanin or tumor melanosis also can be a feature of these lesions. High mitotic rate, hot spots, high-grade cytological atypia, can be necrotic changes and high cellularity. If we see solar elastosis or any other solar damage signs, it is very striking sign of melanoma. Also, it is very important to prove that it is have a atypical molecular profile. And the most interesting category in this spectrum is a typical Spitz tumor. Does it exist? Who believes that this tumor actually exists? Raise a hand. Oh, okay. In my opinion, it doesn't. I'm sorry. I think that it is a heterogeneous group of melanocytic tumor with overlapping histological characteristic between benign Spitz nevi and malignant melanoma. And actually, it has a distinguished from Spitz nevus, but present on one or more atypical features, and often has a uncertain malignant potential. It is a gray zone when we put something that we don't know how it will behave in the future. And actually, there was a series of studies when sentinel lymph nodes was removed in patients with atypical Spitz tumor, and it shows that it is a lot of cases when we see in sentinel lymph node deposits of melanocytes with spitzoid morphology. But actually, it is this patient has a favorable prognosis. And this disease has indolent course despite the fact that in sentinel lymph node we found metastatic deposits. What is a typical Spitz tumor? Is it an unusual form of Spitz nevus, low-grade malignant spitzoid tumor, malignant Spitz tumor, or any other different type of melanocytic tumor? With the rise of molecular study, actually, we now understand that genomic landscape of spitzoid neoplasm, it is huge, and it can be both of this tumor. It can be anything of this tumor, actually. And our task as a pathologist, as a scientists, to try to find out what is that actually and how it will behave in the future. A typical Spitz tumor in new WHO classification also exists, and I want to show you that it has a lot of overlapping features with spitzoid melanoma, and actually it is quite difficult in some cases to distinguish it from spitzoid melanoma. And even clinical feature, even histological feature can be quite overlapping. Immunohistochemistry also doesn't help much in some cases. It is very important that this tumors has a mutation in a gene that encodes P16, and if we see diminish or even absence of expression of this marker, it is associated with aggressive clinical behavior. We are getting used to immunohistochemistry, but actually in melanocytic lesion with uncertain malignant potential, it not always helpful. And cyclin D1 that we stain for conventional nevi, it can help in avoid melanoma, but doesn't help much in spitzoid neoplasms. So there is a series of studies that shows that cyclin D1 overexpression can be controversial in a case of spitzoid neoplasm, but P16 can be helpful, and sometimes it is a prediction of clinical behavior of this tumor. And also, I want to say that molecular genetic studies give us a lot of help, and now we know that profile of spitzoid neoplasms, it's a very huge category. When we see a BAP1 negative lesion, or so-called BAPoma, or ALK fusion lesions that it is ALK fusion. It is very common for spitzoid neoplasm with plexiform pattern of growth, and we used to call this lesion alkoma. Unknown also exists category of unknown genetic abnormalities, and we call it anknoma and something like that. A lot of tumors exist, and now we know that it is different types of tumors with different clinical behavior and so on. But what to do if molecular studies we cannot perform molecular studies? For that reason was diagnosed clinical morphological assessment when we can judge about clinical behavior of this tumor. Depends on age, diameter of the lesion, involvement of subcutaneous fat, ulceration of the top, and mitotic activity of this tumor. It's a kind of prediction of clinical behavior, and depends on accounting. It divides on tumors with low risk of metastatic progression, intermediate risk, and high risk. I want to share with you a case of a young girl. There was a lot of tumors on her trunk and extremities. She was 60 years old on the moment of first surgery, and morphology of this tumor was very interesting. In the center of the tumor, we saw a lot of epithelioid melanocytes that show no maturation in depth, but it wasn't very methodically active. And on the site of this tumor, there was a lot of melanocytes that shows conventional morphology, like regular conventional nevi. And when we look at it more carefully, we understand that it is sheets of melanocytic cells that sometimes aggregate even in multinuclear cells. And when we stain BAP1, it appears negative staining in the nuclei. So it was called BAP1 negative tumor or BAPoma. And actually, this patient has a high risk of development of mesothelioma, uveal melanoma, or cutaneous melanoma, and also liver cancer. It is really important to recognize this tumor and to understand what is that, because this patient should be carefully followed up. And if we are in the context of the history of spitzoid neoplasm, now we understand that actually from the very beginning, when Sophia Spitz called it juvenile melanoma in 1948, to now we understand a lot of interesting facts about this tumor. We understand the clinical behavior, and tumor category as atypical Spitz tumor become smaller, and it is good because we can predict the behavior of it. And to sum up, I want to say that in assessment of spitzoid tumors, it's very important to do a clinical morphological correlation and to assess everything, clinic, histological features, and molecular profile. Use all available diagnostic approaches to keep the certain diagnostic category of atypical spitzoid tumor as small as possible, and publish unusual cases and discuss them, because it is very important to find new features of it. It is very important also to do a careful follow-up of this patient, because we don't know how it behaves in the future. So thank you for your attention, and thank you so much. If you have any questions, I will be happy to answer it.
Just to start, thank you very much, Antonina, for a very comprehensive discussion on Spitz nevi, Spitz tumors, and Spitzoid melanomas. I feel I have to say something because I have a passion for Spitzoid lesions, which started when I was training in dermatopathology in Belfast and has lived with me ever since. And there are a couple of things that I do want to say that I think are very important. And the first one is Spitzoid melanoma in young people is almost vanishingly rare. That's the most important take. From my perspective, it's the most important. So although you will see a Spitzoid melanoma presented at a case seminar or at a meeting or on websites, in your daily practice, the chances of you ever encountering a case of a genuine Spitzoid melanoma are maybe once every 2 or 3 years or something. They're terribly rare. So when you start with a Spitz lesion, and it's from a 12-year-old, it's 99.999% going to be benign, and that's all there is to it. And if you keep looking for stuff to call it malignant, you'll always find things, and you have to keep things in perspective. Antonina brought up a very important point, because I remember I diagnosed a young person with a Spitzoid melanoma. I have to say it was a long, long time ago, but my diagnosis was based on a tripolar mitotic figure, and we now know that tripolar mitotic figures don't mean anything. And there was a case presented on McKeeDerm a little while back, and the reason the person posted the case was because of this tripolar mitotic figure, and lots of folk wanted to call it melanoma, but that's what it wasn't. Now, the other thing I wanted to mention before opening the questioning was just to talk about atypical Spitz tumor, atypical Spitz nevus. Antonina, I think, nicely showed that the group of lesions that tend to get called atypical Spitz tumor, atypical Spitz nevus, is contracting. With molecular genetic studies, with immunohistochemistry, with sequencing and so on, we're beginning to be able to pull out, we now can pull out bapoma, we can pull out alcoma, and no doubt other ones as well. And I think the issue that to me is fundamental in atypical Spitz tumor is that yes, sometimes you don't know whether a Spitz nevus is a nevus or a melanoma. So I don't think that one can confidently every single time make a distinction. That would make life just too easy. But the problem is, and I've noticed this over the years, people's confidence in diagnosing Spitz nevus has gradually got less and less and less. And people tend to, rather than go with common sense and recognize a lesion as a Spitz nevus, they look too much at high power and they see two mitotic figures and they say, oh God, two mitotic figures, I don't like this. It's got to be an atypical Spitz nevus. And so atypical Spitz nevus really consists of, to my mind, 90% Spitz nevi that people didn't have the courage of their convictions, and perhaps 10% which are going to turn out to be bapoma, alcoma, and very rarely Spitzoid melanoma. So I've said all I have to say. So now would people, because this is one of the most important topics we're discussing today, so we should have lots of questions from the audience.
Thanks, Antonina, for the nice talk. I missed half of it because of technical issues on this side. Just a question, you know, like, because you need to advise clinicians sometimes in the report. So atypical Spitz nevus, do you guys give them, like, you know, a comment, excision of scar or something, you know? Just like melanomas kind of thing?
Thank you for question. Actually, in new WHO classification, it treated like tumors of fourth category, and we recommend to excite it with 0.5 millimeter site of excision. It's kind of, we recommend it to treat it as tumors with unknown biological potential. Also, we also put a comment that we have to do a molecular study just to know what's going on. Any other questions?
Can I ask the audience, how many of you have diagnosed spitzoid melanoma? If you put your hands up. Jared? So there are a few of the... Okay, how many people in the audience are dermatologists? How many of the dermatologists have had patients with spitzoid melanoma? One. You see, that probably puts it into perspective a little bit. You showed very nicely the histological subtypes of Spitz nevus, and it's interesting how difficult we make our own lives by subdividing and subdividing and subdividing. Because I tend to be a lumper. I don't like too many classifications. To me, I like Spitz nevus, spitzoid melanoma, and if I'm really pushed, I'll say I don't know. But having all these I think subdivisions are useful in the sense that if you see something funny, like pseudoepitheliomatous hyperplasia, you can look up the books or the literature and oh yes, somebody described that, so that's okay. I don't need to think I'm looking at a squamous carcinoma and the Spitz nevus. But do you have problems at all with distinguishing desmoplastic Spitz nevus with a desmoplastic melanoma? Because that's a question people often ask me. What are your thoughts?
Actually, thank you for your question. And I'm also a very lazy person. I don't like new classifications with a lot of entities in it. But, you know, sometimes when I first diagnosed lipoma, I was really happy because I know what to do with that patient. I know how to follow up with her. And actually, sometimes it is really important to recognize additional entities. But in a case of desmoplastic melanoma and desmoplastic Spitz tumor, I really like the book of Massey about melanocytic neoplasm, and there is a quite good criteria about these entities. But if it is a young person in a young age and we don't see any solar damage in this patient, it is quite, and some epithelioid morphology, sometimes it can be desmoplastic Spitz, and we diagnose it like that. But if it is old patient with solar damage and we saw some lentiga maligna on the top, it is more like. But yes, of course, it has a lot of problem distinguish between them.
I was just thinking when you mentioned lipoma. When I encountered lipoma, I it produced a bad reaction in me because I remembered back then to when I was working at the Royal Victoria Hospital in Belfast, and that was 40 years ago. I diagnosed melanoma on a scalp excision, and I said it was melanoma arising in a nevus. And later on, when I reviewed it, I decided it was a rhabdoid melanoma because rhabdoid melanomas had then been described, and that became, everybody wanted to have their rhabdoid melanoma. It's one of these things when somebody describes a new entity, the whole of your life is transformed because you got to get one of these so that you can walk proud that you've got one of them. So then I decided it was a rhabdoid, and I photographed it and showed it in lectures as rhabdoid melanoma. But now I know that was a misdiagnosis too, and it's actually a bapoma. So I've made 2 misdiagnoses on the one case, which is probably quite good. But fortunately, I don't think the patient came to harm in any event, you know. Anybody else got any questions?
Antonina, I have a question.
Great.
So it seems to me the spitzoid tumors that are the most problematic are ones that are arising in not old and not young. So this category of patients in their 30s, perhaps, that have a newly acquired lesion with histologic features of Spitz tumors. Yeah. How would you guide us in moving forward? Are we to do immunos to reassure us, or are there genetic studies we should do to reassure us that this young adult has really a benign lesion?
At least, thank you for your question. At least I perform a P16 staining just to quickly recognize that this tumor has no Z mutation in this gene, and that it will be more indolent course. And of course, I prefer to see a molecular genetic studies in that case, just because sometimes they can behave badly. Rare, but still.
Any other questions from
Yes.
anybody?
I'm sorry, Kim.
Oh, great.
Yeah. So what molecular studies are you doing?
We do genetic studies with our partners in Czech Republic, and they do a lot of TERT mutations, CDKN2A, and so on. There is a lot of panels.
A question here.
Question from Nima.
Yep. Okay. Hello. Antonio, thanks very much. It was a great talk. I really enjoyed that. Just a comment on bapomas. So, I mean, the vast majority of bapomas are actually sporadic cases. So the number of familial cases are very, very low, maybe less than, 5%. So I think we don't really need to be that excited if we diagnose a bapoma because a lot of them are sporadic. I think the best thing is just to ask clinicians to look for kind of family history. If there is any suggestion, if there's multiple lesions and things like that, then we can kind of progress to more kind of genetic testings, because those genetic testings quite expensive and time consuming. And the other thing is, like, there is some evolving evidence that some type of bapomas are more likely to be associated with actual kind of familial syndrome. For example, if you see a junctional component in a bapoma, it's a kind of suggestive. If you see a bapoma with a combined nevus and you see loss of a staining in both components, or you see something that looks like a conventional nevus, doesn't really have any epithelium, it says, but shows BAP1 loss, that's a higher chance to be associated with kind of familial BAP1 kind of loss syndrome. But I mean, in general, I think the vast majority are sporadic and, don't really need to do much about it. Is that the same kind of,
In this case, this patient had a lot of these tumors, and they continue to rise.
Yeah, exactly. That's probably the best kind of, Okay. Thanks.
Thank you.
A question. Thank you very much for the talk. It's very interesting. I'm kind of a dinosaur, not really into the molecular area yet, but it's with, I'm luckily worked with children, so we don't have to deal with the range of age between the adults and youngster. Recently, we have a case with the typical feature that you show hot spots and necrosis and sheets and nodule, but it's in a 12-month-old youngster. It's on the lip, so we kind of thinking about well, we cannot rule it out, the malignant Spitz tumor, but it's in a young child.
You say 10 months old?
12 months. Yeah, so we signed it out as at Spitz, nevus, with a comment and suggestion to re-excise with a minimal margin and cross our finger. The last time I encountered something, well, we saw it's in consultation as a typical Spitz tumor. The child died. She's 8-year-old, so it's way back when I first started 20 years ago. So I'm still in a limbo. I don't like the term of a typical Spitz tumor, but I have to live with it. So I try to guide our dermatologists as clearly as possible. But any comments that I should do more for molecular now, even for children, or?
Thank you for interesting case. And actually, when I read a new chapter about spitzoid tumors in new WHO classifications, there was a case of 11 years old child who died because of spitzoid melanoma, and I think it was during the 1 year. And in this case, I always think that probably this category wide. Spitz nevus, it commonly affects children, but I don't want to be that person who misdiagnosed Spitz nevus and spitzoid melanoma. That's why I better want to read a molecular genetic study and so on, and I want to know everything about this tumor. And my point in my presentation was that try to find out everything about it, just to know what's going on. And maybe it helps, but maybe not.
I just wanted to bring up one point that came into my head, which we haven't touched on, and that is the problem of the shave biopsy.
Oh, definitely.
Which I think is responsible for a lot of the problems, because if you've only got half of the lesion, you don't see the deep part, you can't diagnose it. How do you formulate your report when you've got a shave of a part of a spitzoid lesion? What do you say?
I try to avoid rude words to person who did it, and actually I try to say that I can assess everything. I definitely cannot assess everything. Yeah. I cannot assess deep aspects of the lesion. I cannot assess symmetry of it, and so on. And also I recommend all that testing that I do in general, like in surgical excision.
Any other questions?
Hot topic.
Cool. Глубоко уважаемая Антонина Вячеславовна, спасибо большое за прекрасный доклад. И я хотел бы подчеркнуть, что классификацию, которую вы приводите, как раз-таки она имеет практическое значение для определения прогноза в клинике. И это невероятно ценно. Вопрос достаточно банальный. При шпицоидных меланомах наблюдали вы в подлежащей дерме воспалительный инфильтрат во всех ли случаях и имеет ли он прогностическое значение в плане клиники?
Игорь Ванифатович, спасибо за вопрос. I'm sorry. He asked me about infiltrate in the derma. Does I see it often, and how it influences the prognosis?
The lymphocytic infiltrate?
lymphocytic infiltrate. And actually, it's not so important like in conventional melanoma. I read few articles that shows that actually lymphocytic infiltrate and spitzoid tumors not so important like in conventional melanoma, but still it is important. And it doesn't influence the prognosis very much, but still it is important. I saw a few tumors that was very suggestive to spitzoid melanoma, but I haven't seen any infiltrate. Sometimes it's happened even in conventional melanoma.
Okay, thank you very much, Antonina. I think you can now breathe the sigh of relief. Your time is up, so we're going to move on to the next presentation.
Yeah. And
that was great. Well done.
Thank you so much. Thank you. Your presentation.
Yes.
May I just? I'm sorry. I have to take a microphone for a while and present next speaker. I'm really proud that this conference is held in Kyiv, and I'm really proud that my good friend come to that conference and will give a speech about clinical morphological correlation. Thank you so much. Phillip McKee, next speaker.
Thank you. So the first question I have to ask you are you all awake? If anybody's asleep, could you raise your hands just so that I know what's, because last night there was an awful lot of wine being consumed, and I don't know how people actually got themselves home, let alone up in time for the meeting. Now look, this first slide is the most important slide really. You have to digest this. Diagnosing dermatopathology, well, diagnosing any pathology depends upon clinical information, because the clinical information gives you the background to the patient, and in skin pathology, the clinical information is the gross pathology. Now, those of you who do or did surgical pathology, and you would have this great length of colon, and you'd dissect it out, and there'd be a huge fungating tumor in the middle of the colon. Well, you don't need a microscope really, do you? You just say the patient's got cancer of the colon and get on with it. In dermatopathology, when the dermatologist looks at the lesions, it's the equivalent of you gazing at the colonic carcinoma. My picture's gone. Oh, yes, right. Now, so on the left, we have the dermatologist. Mind you, it's obviously not a very good dermatologist. Why is this thing flickering? It's giving me nystagmus. I think, if you don't mind, I'm going to take my... Unfortunately, I can't point at both screens, so those over there will have to sort of try and look over here. You can see that the dermatologist isn't very good, because they're going to give the patient pills no matter what the lesion is. And there you can see yourselves, the pathologist. So you need to work in conjunction. Now, nothing's happening. My remote's not working. Can you advance it for me? Yeah, if I ask you for next slide, that'll do the job. It'll save me having to do that. Now look, here's a perfect example, you see, of clinicopathological correlation, but it's not really. There is a catch in this, you see. So we have this patient She's a 36-year-old lady, and she's got these rope-like lesions around her neck. She looks, in fact, as if either somebody's tried to hang her or she's tried to commit suicide, but she didn't really. She just developed these lesions. And histologically, you can see that they're composed of very, very nice, non-caseating, naked granuloma. Can I have the next slide, please? Can we move on a slide? Whoops, no, if you go back one. Right, so those of you who are, well, you're all dermatopathologists or you wouldn't be here, you'll have this list in your head of all the things you think about with non-caseating granulomata. It's important to remember that tuberculoid lesions don't always caseate, so tuberculosis is often in the differential diagnosis, even in something that looks like sarcoid. So we have all of these. We have all these differential diagnoses, but then you get the accurate clinical information, and the accurate clinical information is the patient is receiving alpha interferon therapy because of hepatitis C infection, and her sarcoidosis was precipitated by the alpha interferon, and when they stopped alpha interferon treatment and gave her something else, her sarcoidosis vanished. So this was a drug-induced sarcoidosis. Next slide, please. Now, down to the, I think I can walk around now, which makes life much, much better. There are several, this again is a sort of a rule of thumb for when you're doing your cases. The first point is, you either recognize something or you don't. If you don't recognize it, then you've got no chance at all. You may as well go home, because you're not going to get anywhere. It's not going to help. If you say you think it's a tumor, but you don't know what it is, then you say to yourself, well, what immunohistochemistry should I use? And you look at it and you think, well, I don't know what it is, so I'll use 20 antibodies, and you hope and pray that one of them will stain positively, and it does. But then you discover that that antibody stains 20 different tumors, so you're back where you started. So that's the first problem with dermatopathology. And to get around that, you need to have lots of colleagues. You need to make sure you work in a department where other people can tell you what the answer is. Or, nowadays, we have social media, so you can post your case and you can say, here's a tumor from a 20-year-old on the head. I know it's a tumor, I don't know what it is, please help. And then you've got, well, now we've got over 12,000 people gazing at your tumor, and hopefully one person in the 12,000 will know what it is. So, now, the next important thing, and I'll walk across to show that I have no bias. I'm walking across. This is the next thing. If you get a psoriatic eruption, and you look down the microscope and it looks psoriasiform, if the dermatologist says, rule out psoriasis, then you rule it in. If they say it's psoriasis, it is psoriasis, and that's the end of it, and don't waste any more time. Just say yes. Now, if they say it's looks psoriasiform, but we don't know what it is, then you have a problem, because the dermatologists are letting you down, and they're depending upon you, and then it becomes very, very difficult, because then you've got to start thinking, and if it's early in the morning, you don't like to think, so you might just choose to say, well, I think it's psoriasis, and have done with it. But I think it's important that you don't do that, because what a lot of people, particularly in the States, they'll write a report saying psoriasiform dermatosis for clinicopathological correlation, which gets them out of trouble. You see, they don't have to look at it anymore. They look at it for 1 second. It looks a bit psoriasis. So they press a button and it says that, and they can go on to the next case. Now, that's all well and good, but in 20 years' time, when you want to see how many drug-induced psoriasiform dermatoses you have because you want to do some research, you won't know, you won't have any, because all you'll have are 16,000 psoriasiform dermatoses for clinical pathological correlation. So I think you should always make the effort to try and get to the bottom of the problem. Just before I forget, I have to speak to my wife because I'm very, very bad with timing. And when I start, I can sometimes forget that I have to stop at some point. So I need, Gracie, you to tell me when 40 minutes are up. Right. Now, so here's the other thing. Now, the Ukraine, oh no, can we go back, please? I have to talk about the telephone, yes. People often make the comment that they haven't got any clinical information, and to me that's unthinkable. It's not allowed, and you should never report a case without clinical information. If the clinician can't be bothered to tell you what the clinical information is, then you reciprocate and you don't bother reporting the case. It's as easy as that. And then they'll phone up and say, what's happening to my case? And you will say to them, well, you didn't tell me anything about the patient, so tell me the patient's history and then I'll tell you the answer. And that way, slowly but surely, you will succeed in getting the dermatologist or the surgeon. They will learn to behave themselves. It's just a matter of pressure, and you have to keep on at it. And it's not just for your satisfaction. It's for your safety. Because if you start reporting cases without clinical information, you are guaranteeing that you will end up in court sooner or later. And also, the patient sooner or later, one of your patients is going to suffer badly because you screwed up the diagnosis because you didn't have the clinical information. Can I have the next slide, please? Right. So, good information is gold. And this is gold. This is a gold. Just to show you that Ireland has got something in its favour, that's a big chunk of gold from a gold mine in Slievamore in County Clare in Ireland. So gold is good, and good equals clinical information. And garbage out is rubbish, and as you can see, that's the Great Pacific Garbage Patch. And that's where all the clinicians who don't give us clinical information, we need to dump them into the middle of that. Next slide, please. So, on a really good day, well, no, actually, this is what I demanded. When I was in Boston, I was in a position of power, and I could be very firm, and I could demand things, and I could make them happen. So I was very, very strict, and the clinicians. It's surprising sometimes, you know, in the real world, they don't even tell you the name of the patient. The patient has to remain incognito for some reason. So you need the name. The age is a pretty useful bit of information. The sex is useful because, for example, men don't very often get pregnant. So, you know, it's quite handy to know that it's a she and that she's pregnant, or there's something else going on. it's useful to have a description of the type of lesions. Are they papules? Are they pustules? Are they plaques? Is it a tumor nodule? Is the hair falling out? Whatever. What part of the body is affected? Let's say you have blisters. If the blisters are on the back of the elbows, the patient's probably got dermatitis herpetiformis in a subepidermal blister. If they're on the flexural aspect of the arm, they're more likely to be bullous pemphigoid or linear IgA disease and so on. And the rest of this, it's very important to have the drug history. That's another thing you mustn't forget about, particularly with inflammatory dermatoses. It makes life much easier. And nowadays, and I think we're going to have a talk on dermoscopy, that's becoming very important, and it's really useful in melanocytic lesions. And this is a patient who, as a child, one of her friends stabbed her with a pencil. And this is many, many, many years later. And that's graphite in the skin with a granulomatous reaction. And the clinician, when they saw that patient, they thought it was a blue nevus, which is a pretty reasonable diagnosis, but in fact it's a graphite granuloma. And could I have the next slide, please? Melanocytic lesions. Now, the clinicians have the ABCDE rule, and I've written that down there, which they use when they clinically assess a patient's nevi. They look at the various aspects. Which is great because it gives you a good idea of whether the patient is suffering from a benign lesion or likely to be malignant. But what's important is the clinician should give that information to the pathologist, because we find it just as useful. If somebody says to me on a report, female, 16 years, 4 millimeter diameter, round, uniformly pigmented papule of 6 months duration, I don't even need to use a microscope. I can just say that's a nevus, and we can save a lot of time. But in reality, obviously, we do look at it. But the point is the clinical information tells you the diagnosis. You know what it is before you look down the microscope. And I've illustrated you're getting ahead of me. Anyway, that doesn't matter. This is a case that I've shown many, many times. I've shown it on McKeeDerm, and I've shown it at conferences, and I'm making it easy for you because I put the clinical picture showing you that it's a little baby with a congenital nevus. But if you look at that histology, with the degree of cytological atypia, the huge nuclei in the dermis, the dermal mitotic activity, the involvement of the appendages, as you see in the middle picture there, if you didn't have that slide there, and I said to you that was a biopsy from the back of a man aged 42, if you didn't call that melanoma, there would be something wrong with you. So you must have clinical information. Otherwise, if you didn't know that was from a neonate, you would say that was a melanoma. And the dermatologist mightn't be that good. And they may accept your diagnosis, and suddenly this 6-week-old baby has got diagnosed with melanoma, which will stay with it for the rest of its life, when in fact it's nothing of the sort. So very careful. Next slide, please. This is the case I had to show you because it's fascinating. This is when I was in Boston, and I got this ear. It was a whole ear, and the clinical information said excision of ear. And I thought, well, that's very good. Why have they excised this patient's ear? So I decided I'd call up the surgeon and I'd ask him why he chopped the ear off. And he said, because they asked me to. So I said, who asked you to? And he said, the doctor at a different hospital asked me to excise this ear. So I said, well, any ideas as to why he asked you to excise? No, I have no idea. I'm just the surgeon, I just chopped his ear off. So that's really good clinical information. But I have learned over the years, when you get scar tissue and there's no clinical information whatsoever and you can't get any, the one thing you do not want to miss is desmoplastic melanoma. So when I get scars that I don't know what they are, I always, almost invariably put immunohistochemistry, and this was the S100 protein. And eventually, I got back some weeks later, that the patient had had a melanoma removed from the ear. And so my diagnosis of desmoplastic melanoma was correct. Next slide, please. And actually, we'll move on. Next slide, please. Okay, this is again, it's another demonstration of you need to have some clinical information. You see, if you look at those four pictures, they all show an epidermotrophic infiltrate by atypical lymphocytes. And my question is simply, which one of these is mycosis fungoides? And the next slide, please. These are just pictures of what they would have been: pagetoid reticulosis, mycosis fungoides, a carbamazepine drug reaction, and ATLL. And the next slide, please. There are the answers. The first one is pagetoid reticulosis, and this is a T-cell mycosis fungoides-like drug reaction, and that's something that you will encounter every so often. Of the lymphomatoid drug reactions, the ones that I've seen most frequently have mimicked mycosis fungoides very closely, so you do have to be careful. Next slide, please. Next slide, please. Now, this is my second favorite case ever. My favorite case comes after this one, but this is my second favorite case. And this was a middle-aged male who presented with nodules on his arm, and it's a case that Eduardo shared with me. I don't have the clinical, so I borrowed a photograph from this journal, from the Indian Journal of Occupational Medicine, and it would have looked like that, I suppose. So the next slide, please. Next, there we are. Oh, no, if you go back, there we are. So this is deep in the subcutaneous fat, and you can see there's masses of inflammation, lots of foamy histiocytes, necrosis, neutrophils, and black blobs. And the next slide, please. And this is a close-up view to show the black particles. If I hadn't used this before, I'd ask you what it is, but the trouble is, some of you will know what it is, and then you'll look terribly clever, and everybody else will be in awe of you for knowing the answer, but it'll be cheating because I showed it. Next slide, please. So those, in fact, are particles of mercury. Now, this is, I think, is the interesting bit, is how mercury gets into your skin. And it's mercury granuloma, or it's not really granuloma at all, it's suppurative inflammation in reaction to mercury. it's very, very rare. When you look in the literature, it's very hard to find any cases. And what I find interesting is sometimes it's a suicide attempt, and people have been known to break a mercury thermometer and then jam the thermometer into their skin in the hopes that they'll die from mercury poisoning. You're looking as if you don't believe me. It's true. And I like this one. I do like mercury-tipped bullets. And what these are hollow point bullets that have then been filled up with mercury. Mercury vaporizes, so when the bullet's fired and it hits you, the mercury expands like that, so the fragments of shrapnel from the bullet spread even further. So, and those, I think, are sometimes used. And then, of course, you get mercury in tattoos. And when I was a young person, I don't know why I said young person, really. When I was a young man, I think I've got caught up with political correctness. We used to get mercury put into our teeth. So if you remember the Mad Hatter, the Mad Hatters went mad because of their using mercury when they were lining hats. So if you get too much mercury in your teeth, you can go mad from old-fashioned dental work. So the next slide, please. And this is the case that I borrowed, the clinical, and this patient had got some wound and had used a mercury-containing compound and rubbed it all over his abdomen and arm, and so you can see the mercury on his front of his chest. There's an awful lot of mercury, so he must have used an awful lot of paste to get that lot. And the next slide is really, really good. You see, you didn't believe me, madam. You did not believe me. Now, this is not a bronchogram, and it's not an arteriogram. This is the patient's pulmonary vasculature outlined with mercury. The patient committed suicide, and isn't that just such a beautiful picture? I think it's just so lovely. So really, that whoever this unfortunate person was, they did us a favor, because we've got a perfect example of pulmonary vasculature. Next slide, please. And the next one. Now, this is my favorite ever. This is a great case, and nobody has seen this before. None of you have. So this is quiz time. This is where you guys have got to work for your living. So this is an adult male. He had a sudden onset of an erythematous lesion on the back of his metacarpophalangeal joint of his thumb. So that's the clinical. Well, it's not the clinical of my case, but it's a different case, but it'll do. Next slide, please. And there is the histology. Gosh, there we are. There's a lot of papillary dermal edema, as you see in highlights there and there, and there was an inflammatory reaction which looked vaguely granulomatous. So the lesion, it may have developed very suddenly, but it's been around for a little bit of time because it's got a chronic inflammatory reaction. And the next slide, please. And here we see tremendous vascular congestion. Sorry, I'm trying to find the pointer. And some areas of necrosis, as you some necrotic debris there. Right. Now, if anyone can tell me what this is, you will get an invitation to the gala dinner tonight free. So it's a hell of a prize. Fellow Prize. Anybody want to suggest what that might be? If I tell you, I've been looking for this for 30 years, it tells you it's rare. Well, it's not rare. I can tell you that 3 million people in the world will get this every year. 3 million people. The next slide, please. There you are. That is a snake bite. And I wanted a snake bite just because, you know the way you want things. I mean, I want, there's so many things that I want that I haven't got, and I'm not going to get either. But I did want a snake bite very, very much. I thought it would be lovely to have the histology of a snake bite. Now, that histology is just completely non-specific. It could be anything. It doesn't really matter. What matters is it is a snake bite. So you cannot. How many people have seen the histology of a snake bite before? Now, don't anybody dare raise your hand. Excellent. Nobody has. Good. So that's taken me 30 years. And when I lived in Ireland, as you know, we don't have snakes there. St. Patrick got rid of them all. So there's no way. But when we lived in Arizona, we used to have lots of snakes. But I still never managed to. Well, people got bitten by snakes, but they didn't get their skin biopsied for some reason, which to me was a great disappointment. Anyway, so that's Bothrops, and that's the other thing to remember. We use the word, we say snake bite reaction. Snakes don't bite, they envenomate, but they don't bite you. Next slide, please. And that's, I think we'll just go on we'll forget about that. If you go to the next slide, please. Next slide. Right, now this is a super case. How much time have I got left? I think I'm 30 minutes now, so I've got 10 minutes. 20 minutes to go. That's great. Before I have to ask you this. You've got so many chevrons on your jacket's arm. Does that mean you're a major general?
Kind of.
Kind of. Well, I thought you must be. You're pretty important because I've been looking at those thinking, I hope she's not from the security services and I'm going to get arrested. So, this is a biopsy from a female teenager who presented with vulval ulceration and edema. And it's really carrying on from when I started. I showed you the sarcoidosis. So I thought I would carry on with a bit of more of the granulomatous inflammation. And I hope that you can see there are granulomata just deep to the squamous epithelium. And the next slide, please. So we've got a nice granulomata with giant cells and lots of lymphocytes. And the next slide, please. There's a close-up view of beautiful, beautiful giant cells. And the next slide, please. So we come back to the same old story, the differential diagnosis of all of the things that can give rise to granulomata. And you know, it's the same old story. This is not the patient, but it might have been. This is an article that I got in the Journal of Dermatology case reports, and it's a young woman with vulval edema. And so these are the diseases that you might think about. Next slide, please. So it turns out what the clinicians didn't mention, they said that she had vulval ulceration and edema, but they forgot to tell her she had Crohn's disease. And so this patient, the differential diagnosis becomes easy. Well, unless she has two diseases. So I think you probably would go through the usual ritual of PAS, methenamine, silver, acid-fast stains, and so on, because you can't be too careful. But it turned out that she had Crohn's disease. Now, the cutaneous manifestations of Crohn's disease, it's important that you can get these known. Well, they're not really specific, but erythema nodosum, pyoderma gangrenosum, and so on may be manifestations of underlying Crohn's disease. And sometimes discontinuous, what people like to call metastatic Crohn's disease. I don't like that term because metastatic to me implies cancer, so I don't use it, but a lot of people do. The important thing is sometimes Crohn's disease may present in the skin before the patient develops any gastrointestinal system manifestation, so it may be a prodromal thing. And so it's important, if as a clinician you get a biopsy, vulval or perineal, perianal, in the male penile skin, scrotal skin, and it's granulomatous inflammation, NOS. It's not otherwise specified. It's important to bear in mind the possibility of Crohn's. And the next slide, please. So these are some nice pictures that I got from an article in another article in Dermatology Online Journal, just showing a child with tremendous edema of the lips and scrotal and penile edema and perianal or perineal erythema and nodules, and that patient, that's the histology there. So that's a nice example of a cutaneous manifestation of Crohn's disease. The next slide, please. And I just thought I'd touch on Melkerson-Rosenthal syndrome, because there's a lot of, when a patient presents with granulomatous cheilitis, with perhaps edema of the lips, you sometimes, well, there are many causes from edema of the lips, but one of the causes can be Melkerson-Rosenthal syndrome, where not by definition, Melkerson-Rosenthal includes orofacial edema, fissured tongue, and facial nerve palsy, but most people don't have the triad. They have one or the other, or sometimes both, two of them, or they may have them at separate intervals. And when you look at the histology of the lips in Melkerson-Rosenthal, it is granulomatous inflammation. And sometimes what you think is Melkerson-Rosenthal syndrome turns out to be Crohn's disease. And the next slide, please. And that's just some more examples. And the next slide, please. Next slide. We'll go on to the next slide. This is where it gets really good, because you see, what you've seen so far is Crohn's disease affecting the vulva, but that was not really, well, it was part of our problem, but she had a second problem, which you didn't see in the first slides. And that, oops, if you go back, thanks, if you look down here, you can see there's granulomatous inflammation affecting a vessel. There's one of the ulcers. And the next slide, please. That's the ulcer. And the next slide, please. And the next slide, please. There we are. So she has granulomatous arteritis, and that's a very rare manifestation of Crohn's disease. In fact, I think I've seen granulomatous vasculitis in the skin twice in Crohn's disease, and this is one of them. The next slide, please. Just to remind you that there are other causes of, if you see granulomatous inflammation and granulomatous vasculitis, Crohn's disease is one of them, but you may see it in sarcoid, you may see it in giant cell arteritis, Takayashi's, and so on and so forth. How am I doing? Is my time up? Oh, this is great. I'm enjoying myself. Next slide, please. Isn't that a beautiful giraffe? There we go. Right. Short shrift for the giraffe. Continuing with the theme of granulomatous inflammation, I wanted to show this case because A, it's beautiful, and B, because Grace and I probably have had contact with this disease but managed not to develop any symptoms. So this is a photograph showing the, if you like, it's often called the blastomycosis reaction pattern, which is massive epithelial hyperplasia, sometimes amounting to pseudoepitheliomatous hyperplasia, suppurative inflammation with microabscesses, and granulomatous inflammation. And if you see all of those three things together, you have to think of infection. That's the first thing that should come into your head. And you need to check the patient's clinical information. And here's one terribly important thing. Always check the HIV status of the patient when you start on this, because if the patient is HIV positive, the chances are highly likely that when you discover the diagnosis of this case, you will only have discovered half of the diagnosis, because there will be two diseases or even three in the one specimen. So be careful. Anyway, so when we look at this, we're looking at the histoplasma reaction pattern. And the next slide, please. There's a close-up view there showing granulometer and suppurative inflammation, and there's a little teaser there and there. And the next slide, please. And the next slide, please. Lots of plasma cells. So at the moment, it could be any fungus you happen to like. And the next slide, please. There you are. And this, isn't that just so beautiful? That's like having lunch, isn't it, really? It's so gorgeous. These are the spherules of coccidioidomycosis. They're refractile, they're birefractile membrane, and inside they're a bit degenerate, but those are the endospores of coccidioidomycosis, which, next slide please, which is endemic in the Sonoran Valley, which extends from through Arizona, down into parts of New Mexico and in parts of Southern California, and to the northern parts of Mexico. And it's a dimorphic fungus, so when it's living in the outside world, it lives as spores, which then get activated, usually by rain. So when you're living wherever you live and there's a lot of rain going on, once the rain stops, the spores germinate and they float up into the air, and hey presto, you start inhaling them. And one of the big risks in Arizona are are these dust storms, and they are notorious for carrying coccidioidomycosis. And when we lived in Arizona for quite a few years, and the last few years we lived in Phoenix, and we had two of these dust storms, and they really are enormous. The one that we had, the last one, was 20 miles wide, it was 2 miles high, and it was 40 miles long. And when the dust storm's gone through, everything is covered in dust. And so the dust brings with it coccidioidomycosis. Next slide, please. And if you're exposed to this fungus, the vast majority of people, nothing happens. You just become positive for the coccidioidin skin test. So it'll show that you've experienced the disease. 5 minutes. Well, this will be my last case then. About 5% of patients develop pulmonary disease, which is very like tuberculosis. And people with pulmonary disease may then develop systemic coccidiomycosis, which can present with skin lesions, or alternatively, as I'll show you in a moment, patients may occasionally get it from inoculation, from a stick injury, or even the thorn of a rose thorn. You can get it injected into your skin. This is a patient with systemic disease, and you can see lots of shadowing in the lungs. And my last slide then, I think, no, we'll forget that one. The next slide. Just the cutaneous manifestations. The commonest in primary skin lesions is you tend to get a nodule which may ulcerate, and the patients, as you see here, you get sporotrichoid spreads. You get this lovely group of papules growing up the lymphatic trunk. And the next slide, please. Next, we'll ignore that. This is I just wanted to show you, to compare the cutaneous lesions with the septate hyphal forms of coccidioides in culture. So thank you very much. It's been a lot of fun talking to you. I hope you've enjoyed yourself, and I hope you've learned, well, something at least. Thank you very much.
It's yours. It's also yours.
Thanks.
The next.
And if you have any questions, I'm very happy to endeavor to answer.
I have one small question about, have you ever seen a granulomatous periolar dermatitis, and how it can be distinguished from Crohn's disease?
It can be very, very difficult, and I think the answer is one has to. Crohn's disease can present in so many different ways, and so I think you have to be aware of it, and you have to be aware that it may present in the absence of any bowel involvement. So perioral granulomatous dermatitis is unlikely to be Crohn's disease, but it might be. And the only way you'll know is following the patient up. Just in that vein, I remember a patient who presented with granulomatous disease of the ear that looked like sarcoid. And the patient was diagnosed as having sarcoid of the ear, and several years later developed Crohn's disease. So that's not, to my mind, it depends on clinicopathological correlation and not on histology.
Is it okay to always put on comments that it can be Crohn's disease?
Yes.
Just to check it?
Yes, I think you should always have that as a little, because it is terribly important that at least the clinician it's in their mind that they need to follow the patient up.
Thank you so much for the lecture, and we will announce next speaker, I suppose.
Yes. Okay, now the next speaker.
It's yours.
No, I just need my bit of paper. Oh no, oh yeah, I see. Our next speaker is...
No, there is a question still.
Oh, the question.
There's still a few questions.
Глубоко уважаемый профессор МcKee, спасибо, что вы в Киеве, спасибо за вашу лекцию, за ее практическую значимость. И у меня к вам 5 вопросов.
Right, well, I can answer that without even a hesitation.
Первый вопрос. Как вы относитесь к высказыванию дерматопатолога Уолтера Ливера? Если патогистологический диагноз какого-либо дерматоза, неопухолевого процесса, расходится с клиническим, то предпочтение надо отдать клиническому диагнозу.
So I would like to ask you, what is your attitude to the speech of one dermatopathologist, Mr. Lever? So he told if pathogistological diagnosis of someone dermatosis, as it is non-tumor process, is different from the clinical diagnosis, what would you prefer? So if it is dermatosis?
What I will translate it. If there is wrong, no, I'm sorry, I should be more careful with translation. If, how do you think, is the Lever quote about if pathogistological diagnosis differ from clinical diagnosis, what do you prefer? It's better to look at clinic or on histology?
Well, I think it depends to some extent on how different they are. If, for example, you say clinically psoriasiform dermatosis with plaques on the knees and the elbows, and my diagnosis is melanoma, then something is very wrong. And so the first thing one needs to do is make sure that the specimen you're looking at actually belongs to the patient. So it's terribly important that you check. And I'm sure you all have. I've certainly had cases where the complete nonsense, and it's become clear that a specimen has got mislabeled and so on. Now, what do I do? If your diagnosis as the clinician is, well, I'll tell you something actually. Here's a really good example. We had a case a while back, and the clinicians had said psoriasiform dermatosis, query seborrheic dermatitis, query psoriasis. And there was this histology. It was the most perfect pityriasis rubra-pilaris I've ever seen. It was perfection. It was checkerboard, parakeratosis, the best you would ever get. So I said confidently, this is pityriasis rubra-pilaris, without giving it a second's thought. I then said, please can you post the clinical images? So the clinician posted the clinical images, and it was perfect psoriasis. So sometimes I sway towards the dermatologist. If you tell me something is something, my starting point is to believe you, and then I see if my diagnosis believes you or if it's not. And if it's very radically different, then I say what I think. So sometimes yes, sometimes no. What I do think is you should never report histology without the clinical information. I know there are people who like to say, I'm a pathologist, I look down the microscope and I give the diagnosis and that's that. I don't want the clinical. Well, that's fine with tumors. That is not fine with inflammatory dermatoses. You do need the clinical. But don't let the clinicians bully you. If you are absolutely certain that your diagnosis is correct, you have to stick by your diagnosis. But sometimes you've got to be flexible.
Можно еще? Второй вопрос. Как вы считаете, для того, чтобы стать дерматопатологом, лучше изначально формироваться как дерматовенеролог или как патоморфолог?
If someone would like to become a dermatopathologist, how it is better to start with? To be firstly a dermatologist and then get a specialization in pathology, or to be firstly a pathologist and then to get some additional specialization in dermatology?
Gosh, I think it can be either way is perfect. If I had my life, well, I would change nothing, but if I had to change something, I think I would like to have done dermatology first and then pathology. But it doesn't really matter which way around you do it. The problem is nowadays, I think to be really successful in dermatopathology, you need a lot of dermatology knowledge. And it's not just from the books. You've got to see patients. You do need to go to ward rounds, to go to clinics. You need to touch people, poke them and prod them and so on, so that you get a feel. Because the trouble is, things don't mean anything until you've actually seen what it really is, and then you think, oh gosh, that's terrible. And you realize what suffering the patient actually is going through. When you just look down the microscope, it's very nice and clean and tidy. So you can do it either way around, but whatever you do, you need both. You will not be good if you just focus on one or the other.
Спасибо. Еще один вопрос. Могут ли результаты правильно проведенного иммуногистохимического исследования привести к ложному диагнозу, ложной интерпретации этих результатов, в частности при лимфопролиферативных заболеваниях кожи? Если да, то при какой патологии кожи это наблюдается наиболее часто и на что следует обратить внимание?
So can the correct immunochemistry lead to a wrong diagnosis or the wrong interpretation, especially in case of lymphoproliferative disorders, skin disorders? And if so, in which cases it can be observed the most frequent? And what should we pay attention to?
Is it immunohistochemistry the most important thing in lymphoproliferative disorders, and can it lead to wrong diagnosis? His interpretation lead to wrong diagnosis of lymphoproliferative disorders?
Well, that's quite a difficult question, really, because I think dermatopathology has become subspecialized. And I think we now have individuals who spend their entire lives looking at lymphoproliferative diseases in the skin. And yes, I'm going to put it the other way around. The commonest T-cell lymphoma in the skin is mycosis fungoides. The incidence of mycosis fungoides is 1 in 100,000 of the population. Therefore, in the United States, there are 300 million, I can't work that out, there's about 1,000 new cases a year spread over the entire country. And that's the commonest one. So many people will go through life and you'll never see mycosis fungoides. When I was in Boston, I worked in the T-cell lymphoma research component at the Dana-Farber Cancer Center. So I was looking at mycosis fungoides every day of the week. It seemed to me it was as common as the common cold, but in reality it's desperately rare. And so all of the other T-cell lymphomas in the skin are even rarer still. So having said that, immunohistochemistry I don't really think it helps an awful lot with mycosis fungoides. People do it all the time. They do CD3, CD4, CD5, CD7, and there's a bit of loss of expression of CD7, a bit of loss of CD5. They say, oh, it's mycosis fungoides. And if you looked at the H&E, it's mycosis fungoides anyway. It either is or it isn't. The only catch is CD8 mycosis fungoides, if that matters, or is it an epidermotropic CD8 cytotoxic T-cell lymphoma when it matters a lot? If the patient has only got one lesion, then you might be thinking more pagetoid reticulosis. So when you get to the rare end of the spectrum, you do need immunohistochemistry to be able to recognize and diagnose natural killer cell lymphomas and some of the more aggressive T-cell lymphomas. But for common lymphomas, well, everyone does it, but and I can't say you shouldn't do it, but it does seem to me that it's an unnecessary expense. If the patient has got typical mycosis fungoides and you look down the microscope and it's typical mycosis fungoides, if you want to do a little bit of immuno, I wouldn't start looking for gene rearrangements. I think that's a waste of time, because if they're not present, it's not going to confirm the patient hasn't got mycosis fungoides. And if they are present, it doesn't mean the patient hasn't got a T-cell, drug-induced T-cell pseudolymphoma. So I think you have to be careful. And again, I think clinical is immensely important. I hope that helps.
Thank you.
Ну уж извините, еще два кратких вопроса. Глубоко уважаемый профессор Маккee, сколько надо было вам примерно просмотреть биопсийного материала или какое время проработать, чтобы вы почувствовали себя более или менее комфортно как дерматопатолог?
So, Professor McKee, how many time did you spend, or for how long time have you been working before you start feeling you confident as a dermatopathologist? Or how many biopsy have you seen before to start feeling confident as a dermatopathologist?
Well, that's actually one of my favorite questions, because I can tell you a story. I started pathology training in 1972 at the Royal Victoria Hospital in Belfast. And in 1973, I'd been 1 year in pathology. And one day, I was walking along the corridor in the pathology department, and in the distance I saw the professor of pathology having a really vigorous discussion. It was an argument, really, with the chief dermatologist. And I was walking along, and suddenly the Professor McKee, she said, "Oh, come here, Philip. Well, I need you." So I walked up and I said, "Yes, what can I help? How can I help you?" She said, "You are the dermatopathologist, aren't you?" She said, "Dr. Martin Bear's complaining that nobody reports dermatopathology because they don't seem to know what they're doing. So I've decided you're going to be the dermatopathologist." So I had 1 year surgical pathology, mostly doing autopsies, so I didn't know anything about skin disease, nothing, even less than nothing. So I bought, whatever it was, the 4th edition of Lever, and I bought Helvig and Johnson's textbook, Dermal Pathology, and I started going to clinics. How long did it take me to get good? Well, I'm still learning. So I don't think my learning curve is over. I think I'm probably quite good. I think I drive better than I'm a dermatopathologist, to be honest with you. I'm a very good driver. I'm quite good at derm path, but I don't want to think I'm too good, because there are so many other really good people that life is just learning, and I'm very grateful to the people in this audience and the people in my group who teach me on a daily basis. Is that a good answer? I think it is.
Спасибо, спасибо. И последний вопрос. Кого вы считаете своим учителем по дерматопатологии?
And the last question, please. Who was your main teacher or tutor in dermatopathology?
If I was honest, I think myself. I'm a self-taught dermatopathologist because I spent 5 years in Belfast, and I didn't have anyone to teach me. I had to teach myself. I had lots of people I read from. Life began with Lever, and then it was the great and sorely missed late Bernie Ackerman, who was a wonderful dermatopathologist. He was a wonderful character too, a very eccentric and interesting man. I think he was an important person in my life. And then there are very many. Dick Sagerbiel from California and Phil LeBois were important in my life, and Marty Mim from Boston is a very important person in my life in dermatopathology. So, thank you.
Let's move on. Let's move on.
Okay. So I think we need to move on, and I'm going to introduce Professor Nima Mesbah Ardakani. I hope I pronounced your name right. Oh, I did. He gave me a thumbs up. Who is, he's on the Faculty of Pathology West, which is based in Perth. Nima is an authority on all matters molecular relating to melanocytic proliferations, and he's currently Associate Professor of Pathology at Murbach University in Perth. So it gives me great pleasure to welcome you, Nima, and I know I'm going to learn a lot.
Oh, thank you. So this is working as well, huh? How much is there? So, thanks very much for a very nice introduction, and thanks to Prof. McKee for just providing such a great platform, and still having such a commitment to teach thousands of pathologists all over the world. And thanks to you and all kind of great Ukrainian people that kind of hosting us here. It's just great things happening. The other thing I wanted to say, I'm kind of not very good in time management. Just let me know if I've just 5 minutes or something, because initially I didn't know how long is this lecture, so I think I prepared something too long, but we can stop whenever you guys are tired. So I'm going to talk about the kind of practical implications and diagnostic applications of kind of genomics in dermatopathology. And basically, more precisely, I'm going to talk about genetics part of genomics, and basically it means the evaluation of DNA or RNA to look for potential or possible structural changes, including somatic mutation, copy number variation, and so forth. And it's important to know actually that the role of genomics in melanocytic neoplasia and melanomas becoming quite important, and probably prognostics and therapeutic part of it is just more important than diagnostics. But for us as pathologists or dermatopathologists, we are more focused on diagnostic part. So to start with just a simple question, what is our task of a dermatopathologist in kind of diagnosing melanocytic lesions? So it's probably in a simple way, we just need to distinguish benign versus malignant. I mean, I don't care. Hundreds of different exotic names been given to melanocytic lesions. By the end of the day, what the patients want to know, or the clinicians want to know, if it is benign or malignant, how they should kind of manage this lesion. So that's very important. And I believe in the hands of a well-trained dermatopathologist, this is a relatively easy job in 90% of cases or 95% of cases, by just looking at the H&E, simple H&E, and correlating with clinical information. And again, it is the most important, but clinical information is really important even in melanocytic neoplasia. However, there are occasionally some challenging lesions, and the reason they are challenging is basically because they show some intermediate morphology or overlapping features between benign and malignant. And it's interesting to know sometimes what seems to be intermediate or overlapping at the morphologic level could be clearly benign or malignant at the molecular level. And that's the beauty of kind of molecular testings for melanocytic neoplasms. Sometimes makes life easier, but not always. So over last decades, we have actually established this fact that melanocytic neoplasia is a stepwise progression from benign or normal state to a malignant state. And this kind of progression often involves accumulation of somatic mutation and copy number variation, often induced by UV radiation. So this is a fact that we know. So I think Bernard Ackermann believed that UV radiation doesn't have any kind of role in melanocytic neoplasia. It's been proven that's wrong. So okay, can't advance this anymore. Can we go to next, please? Next slide, can we? Thanks. Okay, so how are we going to use this information, this fact? So we know that a benign state or a nevus shows often a very, very small number of mutations, often one driver mutation or like kind of kinase fusion in terms of a spitzoid neoplasm or so forth. However, melanomas tends to show a very high level of somatic mutations, copy number variation. So that's something we know. So what about these concepts of borderline lesions? And kind of, we know that a lot of terminologies, including meltop, stomp, sampus, and so forth, has been kind of in literature for so many years. And Antonina just said she doesn't like it, and she doesn't believe in atypical spitzoid tumors. I think I agree with that concept, because we shouldn't really use this term as a waste basket just to reflect our inability to classify. So we should do our best to classify this lesion benign or malignant. And sometimes at the end of the day, there are a very, very, very small percentage of lesions that we don't know, and we should be honest and say we don't know. But just using this terminology, it's not right. So we should use molecular techniques, clinical information, immunohistochemistry, whatever we have, any kind of weapon we have in our arsenal to get to the diagnosis, and that's important. And the concept of intermediate lesions, we like it or not, is just coming. And even WHO book, new book, if you guys look at it, there are quite a number of cases or lesions being kind of considered as intermediate, and they're using this terminology as melanocytoma. And they believe that all dysplastic nevi are intermediate lesion. I don't agree with that concept. I don't think a subset of dysplastic nevi can be intermediate lesions, but I don't think all of them are intermediate lesion. And the other question is, do we have any robust kind of evidence, scientific or evidence at the molecular level, that such a thing as an intermediate lesion does actually exist? And this takes us to this great work which has been done by Boris Bessian and his group in San Francisco, published a few years ago. And basically they looked at a cohort of melanomas that arising in association with nevi or intermediate looking or morphologically intermediate looking lesions in the skin, and they looked at the detailed molecular profile of each kind of lesion in one section. And they actually found out that some of these lesions that they look histologically intermediate, as a matter of fact, they show a molecular profile which is intermediate between benign nevus and melanoma. Basically what they show is usually maybe more than one driver mutation or a combination of a driver mutation, copy number variation, and so forth. So I think that the concept does exist, but using those terminologies is not really right. So let's say if we really want to pursue this kind of classification of melanocytic lesions in more details, what is available to us as pathologists? So there are several kind of molecular platform assays available. Most of you guys probably familiar with FISH and array CGH and kind of classic Sanger sequencing. We are going towards kind of next generation sequencing these days, which is a great kind of robust platform. It can multiplex, and this multiplexing is both in terms of number of samples this machine can run in one experiment, also the amount of data we can get from next gen sequencing. In one experiment, you can get data about somatic mutation, copy number variation, fusions, everything. So NGS is going to replace all kind of older techniques eventually. And also we have techniques like digital PCR, which has a great analytical sensitivity. You can detect mutation at the level of like less than 1%. So if you are having a sample with less than 1% of cells in that sample have a specific mutation, you can detect it by digital PCR. So we're getting really, really good at finding kind of molecular aberration in the lesions. So I also like to kind of explain a little bit how some of these techniques work for those of you are actually sending cases for CGH or FISH and receive a report and you want to kind of correlate that report with your kind of histological findings. So it's a good idea to know how these techniques work. So CGH basically is a kind of a technique interrogating the entire genome by comparing the test DNA with a commercially available reference DNA. And the process starts with kind of finding the area of interest, obviously cutting some unstaged sections and macro dissecting the DNA from the area of interest. Then you label the test DNA with a specific fluorescence color and the reference DNA with a different color, mix them together and hybridize them to a kind of glass slide, which is like a normal glass slide you're using for H&E, but it has thousands and thousands of probes embedded on the glass. So this DNA, two DNA, they compete to occupy those probes and they come up with different colors. Then you scan those slides to a machine and feed it to a kind of software using a kind of quite sophisticated algorithm and comes up with copy number variation based on the intensity of those colors on the slide. So what you're gonna see at the end from the software, in a case of melanoma, like in the kind of upper part of this screen, you see multiple copy number variation, usually with kind of blue columns representing gains and red columns representing losses of chromosome across the genome. And a nevus usually shows often just a very flat line with no copy number variation. Occasionally you can get one or two small aberrations, but often quite flat. So many publications came through last 10, 20, 30 years kind of advocating the CGH. It's pretty good for kind of distinguishing melanomas from nevi. And also Pedro Amgrami and his group came up with this idea about 10, 15 years ago that rather than using CGH, which is a kind of rather expensive and complicated kind of platform, why we're not just using some hot spot copy number variation. So they looked at a kind of a big cohort of melanomas and nevi, and they came up with these 4 probes, which is called melanocytic 4-colored probe, and they validated that, and they believe it has about 87% sensitivity and up to 95% specificity in kind of distinguishing benign or melanomas from nevi. And FISH, how FISH works, so FISH is rather kind of simple. So basically, again, using your FFPE tissue, cut a section. FISH doesn't involve extractions of DNA. Basically, you hybridize your probes onto this section. So there is no DNA extractions, and then you counterstand your sections with DAPI and look at it under kind of fluorescent microscope. And basically, because we have 2 alleles for each gene in our chromosome, in a normal study, you should have 2 dots for each kind of probe. Any variation from 2 dots, it's either a kind of gain or losses of chromosome. So when we did our kind of CGH validation a few years ago in our lab, we found that in addition to melanoma for color fish, there are some other probes or areas of genome that are frequently kind of aberrated in melanomas, including chromosome 9p, 10q, and 8q. And we usually add those probes to a standard melanoma for color fish just to increase the sensitivity, specifically in cases that we are not able to do CGH. And it's, I think, very helpful. Pros and cons, so obviously CGH has a very, very high diagnostic sensitivity because you're looking at kind of thousands and thousands of probes. However, the analytical sensitivity of CGH is rather low, and that means you need at least 34, 35% or 33% of tumor cells in a sample to be confident about your results. So if you have less than that, and it's easy to kind of estimate something quite high in terms of cellularity, but the reality is often less than your estimation. So you can get false positive results. So it's not really good for thin lesions or intraepidermal lesions. And it's quite expensive. Turnaround time of it kind of often is quite long. What about fish? Fish is relatively cheap, quite kind of a fast process. And the beauty of fish is you can visualize the cell of interest and look at the copy number variation in situ. And for that reason, it's good for intraepidermal lesions and even thin lesions, so you can do that. However, the diagnostic sensitivity is probably not as good as array CGH. So I think there are some caveats in interpretation. Again, for those of you not directly involved with this technique, but you receive the report. So fish interpretation sometimes can be very difficult due to truncation of nuclei or overlapping. So it needs to be done in the hands of very good, experienced scientists and also with the help of a pathologist. The other fact is that isolated single copy number variations or polysomies or kind of monosomy, as Antonina mentioned, can be seen in some benign states like Spitzoid neoplasm in proliferative nodules in congenital nevi. You can get polysomy, and it's quite benign, so not every aberration is malignant. And also CGH doesn't have the ability to detect reciprocal or kind of gene fusion and so forth. You need more advanced techniques or fish for that. So just to exemplify some of this problem, this is something that we were just talking about. This is a kind of a lesion on the left forehead of a 38-year-old, showing a relatively symmetrical appearance. Looks quite pale because it's quite sclerotic. When you look at high power in this lesion, you see this kind of some fascicles and some clusters of rather epithelioid cells, some spindly. You could find just one mitosis in this case and normal patchy P16. So CGH in this case showed isolated gain of chromosome 11p, as you can see. So this is basically a desmoplastic Spitz nevus rather than a melanoma. So one aberration doesn't make things melanoma, and this lesion often show concurrent HRAS mutation. So next gene sequencing, I mean, this slide is just to show you how far we have come, in terms of sequencing. So it's always kind of quite mind-blowing to me to realize the first human genome project, just sequencing one human genome, took 15 years, and $3 billion was kind of a spin. Now we can, in one day, sequence 45 human genome in one day with a cost of $1,000 per sample, and this is just showing how far we've come. I'm not going to talk in detail about next gene sequencing, kind of how it works. It's a bit complicated, but it gives us a really, really good data about everything, about the mutations, about copy number variation, everything in one go. So it's a really good technique. So how we actually approach using molecular techniques to help us in kind of diagnostically difficult or ambiguous lesion. Basically, we always start with looking at the slide, H&E, simple H&E, and just kind of try to come up with some differential, or at least think, so this is benign or malignant, or this is ambiguous, but this is more likely to be benign, or this is more likely to be malignant. Selecting appropriate sections, and we often do CGH and FISH in parallel, just to increase the sensitivity. If in need, we can add next-gen sequencing as well. And we always interpret molecular data in conjunction with histology. So molecular kind of information doesn't replace histology. You need to have both together, okay? So we usually, this is what we follow. If it's a borderline histology, suggestive of malignant, but molecular kind of studies is abnormal, it's easy, it is going to be a melanoma. If it's borderline histology, suggestive benign, normal molecular results, nevus. These two latter kind of scenarios are more difficult. So when you have a borderline histology suggestive of benign, then you get abnormal molecular. I guess probably that's appropriate in cases to say, yeah, I'm not sure, I'm getting some contradicting results. Or if the extent of molecular changes is quite extensive, you probably can kind of, even in these cases, rather using a MELTOP category, just say this is probably melanoma because it looks very bad. And also, if you have a borderline histology suggestive malignant, you get a normal kind of molecular result. Again, based on the extent of histology, you can go with the atypical nevus or MELTOP. I mean, I personally try not to use MELTOP because it doesn't help anyone. Clinicians, they don't know what to do with this lesion. So, that's the thing. Okay. So just to show how kind of molecular techniques help us in cases, I just show you some interesting examples from some simple cases to more kind of exotic, kind of rare cases that we would be able to get to diagnosis with confidence based on the molecular findings. So this is a 32-year-old anxious pregnant lady. She's anxious because she's pregnant, and also because she had a lesion on her neck. She's been kind of becoming bigger during pregnancy. And also she had a strong family history of melanoma, so I mean, you should be anxious with all kind of things together. However, the GP who looked at the lesion, he wasn't particularly kind of, interested in the lesion. He thought it's just benign, but because of patient concern, just took a shape biopsy. So this is the shape biopsy, okay? It's a relatively symmetrical polypoid lesion. You see this kind of elongation of these reti ridges, thin reti ridges that I know in some textbooks or some papers have been kind of introduced as a sign of nevoid melanoma, basically representing quite rapid clonal proliferation of cells causing this kind of, thinning of reti ridges. The superficial part of the lesion looks a bit compacted in terms of growth, but the deep aspect looks kind of dispersed and relatively okay. Again, looking at the cells, they show some morphologic atypia for sure. There is some kind of, epithelial morphology. You can see a small nucleoli in the kind of some of these cells again. And then mitosis, and mitosis, and mitosis. So I think in total about 3-4 mitosis per square millimeter. Again, but then looking at the deep aspect of the lesion, this cell is becoming quite small and dispersed. And it is not a pseudomaturation here because the actual size of nuclei of these cells is smaller than, superficial. It's a true maturation, not pseudomaturation. And you see this kind of ectatic blood vessels is telling you this. There is some element of trauma as well. Because of that trauma, you have vascular ectasia and congestion. So P16 was quite normal in this case. HMB45 was positive superficially with loss of gradient loss. I don't really care much about HMB45 to be honest. And Q16 was all right. So the reporting pathologist, I think she was smart and she thought this is just a mitotically active nevus in pregnancy, and I totally agree with her. However, this case has been reviewed in a melanoma kind of multidisciplinary meeting and was called melanoma, with someone who is not just nationally, internationally is one of those guys that you can't disagree with. So all of a sudden, everybody's anxious. The pathologists, the patients, the kind of clinicians. So a lot of anxiety going on. So they send us the case just to give some assurance, basically the primary pathologist, because she said, look, I can't disagree with this person. I need some molecular evidence. What do you think? Anyone thinks this is melanoma? Or mitotically active nevus? Huh? Pregnant. Exactly. I mean, and this is what we found in molecular testing. So pretty much normal, very, very small isolated gain of chromosome 15 could be a germline variant, or doesn't really, CGH doesn't really show a profile of melanoma. So with quite a lot of confidence, the primary pathologist kind of, went back and said, look, this is benign. And I think I have about 2-year follow-up. The patient is doing all right. There's no problem. In contrast, we had another anxious lady who is, again, young, and she noticed a lesion growing up on her left arm over the last 2-3 months. And asked her GP, which actually happened to be her boss as well. So I've got this lesion, growing up, I'm quite worried. And again, the GP wasn't really worried about this lesion. He believed that, in terms of dermoscopy, everything looks all right, but because patient was anxious, they took the lesion out. And this is the lesion, and I understand why the GP wasn't worried about this lesion. It looks quite symmetrical. I mean, relatively small. I think the only odd, low-power things about it, there is a bit of horizontal expansion. I mean, nevi tend to be more vertically expanded. This is more horizontally expanded, and that's a bit kind of odd. Looking at this high power, it's mostly intradermal, very subtle junctional component. But then when you look at it in high power, it's a kind of quite compacted growth again. This is not nested. This is just like sheets and sheets of melanocytes. And when you look at them again, there is a kind of relatively large nuclei, prominent nucleoli. And then when you look at the deep aspect of this lesion, I mean, you get the impression, oh, this is dispersing. This is kind of, maturing. But look at them carefully. I mean, still there is nucleoli, even in the nuclei of this deep cell. So this is what is kind of famous for pseudomaturation. So the cells, they lose their cytoplasm, but the nuclear size is still the same. So this is pseudomaturation, is not. And mitosis. And mitosis. And I think we found about 8 mitosis per square millimeter. Again, HMB45 was quite normal again. Who cares? Never ever put much pressure on HMB45. You can go wrong several times. And P16 was completely lost in this lesion. And I think that's a worry. Loss of P60, any melanocytic lesions, complete loss is a worry, and often represents inactivation of P16 protein. The mechanism could be quite a variety of mechanisms. So the primary pathologists wanted to call this MELTOP. She was concerned about melanoma, nevoid melanoma, but she wasn't kind of, confident enough. Again, this shows how people are using MELTOP category, because they're not confident enough, or because they don't have kind of access to molecular techniques. And we did kind of CGH and FISH, and as you can see, something that looks morphologically so innocent, looks how horrible it looks at CGH level. Basically, every other chromosome shows some segmental abnormalities, including 9p, 10, which are kind of common hotspots for melanoma. Also, we could see homozygous loss of CDKN2A gene, explaining why P16 was completely lost in this lesion. So this was diagnosed as nevoid melanoma. So what is nevoid melanoma? I mean, probably the best description is what Prof. McKee said years ago, a nevus you wish you would have called melanoma. And it is not a well-defined entity. People using different kind of categories or different criteria for it. For that reason, because it's not a well-established entity, we don't know quite exactly what is the demographics of this lesion. Clinically, it can look like just a raised papillomatous kind of nevus, or a kind of compound dysplastic nevus. I've come across this kind of histology classifications, a new WHO book about this nevoid melanoma into papillomatous and maturing a small cell variant. I don't think this classification carries any prognostic weight, but might be helpful in just recognizing them because they can masquerade in different type of lesions. The clues to this, okay, I mean, any expansile growth, either horizontally or vertically, this is probably the first clue in low power. Compacted growth, especially at the deep aspect of the lesion, it is, I mean, they just don't look like melanoma. I mean, with experience, you understand what I'm saying. They're not nested, they're kind of very compacted. They don't look like kind of, a nevus. Mitosis, obviously, if it's there, very helpful. Prominent nucleoli and pseudomaturation, something just to be aware of. Immunohistochemistry, I think for me, the most important one is P16. If P16 is positive, doesn't help you. If it's lost, it's helpful. I think it's very suggestive. PRAME is a new stain. I don't know if anyone's using PRAME now. No, I've seen some big places like San Francisco. I think Eduardo started using it in St. John Institute. People think it's good, it's helpful, but I have no experience. So watch the space for PRAME. And HMB45 could be a big trap. I've seen so many melanomas showing normal pattern and so many nevi showing abnormal pattern. Specifically, be aware about blue nevi, DPNs, and some Spitz lesion. They can show diffuse positivity for HMB45. So be careful about that. Differentials, obviously, with mitotically active nevi. So just remember, nevi are in a very low proliferation state. They're not completely dead, but they are in a low proliferation because the proliferation is kind of continuously blocked by our kind of expressions of genes in our body and by immune system, okay? If there is any physiological changes in the body or change of chemokines or hormones in microenvironment of nevi, they can start to proliferate, okay, and show mitosis. So these are typical situations that you can see kind of, mitotically active nevi. So be aware of this situation. And the molecular profile, again, this is something that hasn't been kind of, well studied. The exact molecular profile of nevoid melanoma, based on limited data, they often show BRAF and RAS mutation. With CGH, often they show multiple abnormalities. I mean, we looked at about 10 nevoid melanoma so far, and all of them showed kind of CGH or FISH or both abnormalities. So I think CGH and FISH are very helpful in cases of nevoid melanoma. And we, at the same time, in parallel, we looked at 14 mitotically active nevi, and we couldn't find any significant changes of those. So I think it's really helpful in this scenario. Okay, so this is a quite interesting case. So this is a 5-year-old kind of a baby with this huge kind of congenital nevus with some satellite lesion, as you can see. This lesion was biopsied when the patient was 1 month old, and the histology showed, unfortunately I don't have a histology, but the picture Prof. McKee just showed, I think that was the histology, showed this pseudomelanoma kind of phenomenon, quite exotic kind of junctional proliferation of melanocytes, but the dermal component was all right. 4 months later, he developed this quite densely pigmented, about 15 millimeter nodule at the site of previous biopsy. So we had a kind of intralesional biopsy, which showing this sharply demarcated, intensely pigmented lesion with background kind of congenital nevus. So congenital nevus on top, dense fibrosis, and this densely pigmented lesion. Again, at the deep aspect, you see these separations between the lesion and background congenital nevus. So looking kind of, at congenital nevus, background congenital nevus, looks quite bland, small round to oval nuclei, nothing worrisome about this part. But then looking at this lesion and high power, you see this quite large pigmented melanocytes showing quite awful lot of cytologic atypia, pleomorphism. Look at that kind of huge nucleoli just looking at you, at your face, and also mitosis. So quite few mitosis, including atypical mitosis, and so forth. We could find up to 7 mitosis per square millimeter. So this lesion deemed to be actually quite difficult, and not thinking about it, just putting it in, in a kind of older person, so everybody might think, so this is just a melanoma. A lot of mitosis, a lot of kind of cytologic atypia. However, we thought that this might be an unusual pigmented epithelioid melanocytoma like proliferative nodule arising in a congenital nevus, which is something that's unheard of. I couldn't find any case in the literature explaining that. So we did molecular studies. Again, such a nasty-looking lesion shows completely normal CGH profile. Fish entirely normal. In this case, we also did a kind of melanoma-specific next-generation sequencing panel. We couldn't find any significant mutation. Just in parentheses, our panel didn't cover protein kinase A and C genes, so these genes were not included in the panel. But most other kind of common driver mutation in melanocytic neoplasm was included, and we couldn't find any driver mutation, and mutation burden was pretty low. Follow-up, patient had re-excision and sentinel node biopsy, and it's found that he had one local positive lymph node and also a metastatic lesion to left groin. Further follow-up, further follow-up, 2 years, patient's doing all right despite the metastatic kind of deposits and everything's about this lesion. So completely lost it now. So the A diagnosis, we thought it's probably a diagnosis of pigmented epithelioid melanocytoma like atypical proliferative nodule might kind of make sense in this case, rather than outright melanoma. Okay, so you want to say something? Oh, you want to just sit here?
You could carry on for another.
Yeah, sure.
10 minutes.
Okay. So 10 minutes, okay. So congenital nevi, as you guys know, they kind of classifies based on the size. They can show quite a variable morphology. Be aware of this pseudomelanoma-like junctional component, especially in neonatal period, okay? That's a pseudomelanoma. They often show NRAS, BRAF mutation, normal cytogenetics, and they behave like a nevus, but they occasionally can be complicated, and they can develop melanoma, obviously. Proliferative nodule is often a kind of lesion which is looks like a kind of distinct nodule, and they often merge with the background kind of congenital nevus. They don't show any significant cytologic atypia or mitosis. However, this subset of atypical proliferative nodules has been also kind of described that they can show a more expansile growth, sharp demarcations, and some mitotic activity. So a variety of morphological type of proliferative nodule has been kind of reported in the literature, from the ones that they can look a bit rhabdoid or they can look like a Spitz nevus and so forth. I haven't seen any report of a PEM-like kind of proliferative nodule. But yeah, and molecular profile, again, they often show NRAS or BRAF mutation, mostly NRAS. They can show whole chromosome gains and losses with RACGH, so be careful about that. It doesn't mean those are malignant, those lesions. And again, they have a clinical kind of indolent clinical behavior. Melanoma arising in congenital nevus often develops in large or giant nevi, and often lesions with multiple satellites. They often show very high mitotic activity, necrosis, and ulceration. And unfortunately, again, the molecular data on melanomas rising in congenital nevi, it's very limited. So the best study I could find just looked at three of them. I think one of the surprising results was like they showed UV signature. I don't know how kind of melanoma in children can show UV signature, but it was there. And also they tend to show NRAS mutation. Clinical behavior, they can be quite fatal, especially in pubertal period. And the mean survival has been reported to be shorter in pubertal period compared to older children. Just a few words about pigmented epithelioid melanocytoma. I'm not going through all the histological features. You all know about it. So Artur Zembovic a few years ago reported that this lesion tends to show loss of protein kinase A regulatory subunit by immunohistochemistry, which was interesting results just because people used to classify this lesion as like a type of blue nevi or epithelioid blue nevi, but I think they are distinct lesion at the molecular level. Further kind of studies to find the molecular underlying molecular kind of changes in PEM found that a subset of them showing kind of PRK a mutation together with BRAF mutation. Some of them show some PRKC gene fusion, and some of them they couldn't find any real abnormalities. I think this is a paper just published a month ago, and this was the largest cohort of PEM they looked at in terms of molecular profile. And on top of what has been reported previously, they found some other kinase fusion, including NTRK and ALK fusion in a subset of pigmented epithelioid melanocytoma. So I mean, we can divide or classify pigmented epithelioid melanocytoma these days a bit further into pure and combined variants. So the combined variant often show a component of conventional nevus as well, and then they tend to show BRAF and PRK AR1 mutation together. However, pure ones, they often show PRKCA fusion and some of them NTRK or ALK. And in terms of clinical behavior, they can obviously metastasize to regional lymph node, but I'm still to hear any cases, any death from pigmented epithelium. Have you ever seen anyone dying now? So no one has died from them yet, so that's good. And my final case, it's a bit kind of crossing the territory of melanocytic lesion, but it's kind of related. It's getting a bit to the soft tissue. So young patient with this lesion on the scalp. So low power shows this kind of infiltrative lesion, mostly in the deep dermis and subcutis. If you go to high power, it's a quite infiltrative growth, almost like a DFSP type growth with kind of entrapped honeycombing of fat in the subcutaneous tissue. There's some predilection for adnexal structures, as you can see. And it shows this kind of very interesting biphasic appearance with areas kind of composed of this interconnecting trabeculae of rather bland spindle cells and areas which looks like a glial tissue with this kind of randomly distributed bland spindle cells in them. Again, this part of the lesion, perhaps the spindles show a bit of atypia with hyperchromasia, occasional mitosis, and so forth. So the fact that this lesion was quite unusual, we asked for a re-excision on this lesion, and this is re-excision. There is some residual. They did a very, very good job in, completely excised with about 50 millimeters kind of, margins, plastic surgeons. And the lesion is still there, same biphasic, again, predilections for adnexal structures. Quite peculiar kind of lesion in terms of morphology. And few mitosis. Okay. In terms of immunohistochemistry, they showed this very distinguishing immunoprofile. It's a positivity for S100 and CD34. And a lot of other immunostains that we did, they were all negative. So negative for other melanocytic markers, negative for epithelial marker, mesenchymal specific markers, and so forth. Patient didn't have any history of neurofibromatosis. So initially, we were not quite sure how to classify this lesion. The possibilities that we had could this be a low-grade atypical peripheral nerve sheath tumor, or could this be a neurocrystic hamartoma, unusual congenital nevus, or a DFSP with myeloid nodule. So we thought molecular studies can be helpful in this case. So CGH was quite normal. However, next-gen sequencing showed a kinase fusion, oncogenic BRAF kinase fusion with some other mutation that we were not really sure what is the clinical significance of those mutations. Importantly, we didn't find any PDGFB gene rearrangements, kind of excluding the FSP pretty much. So we reclassified this as a low-grade spindle cell neoplasm with BRAF fusion, kind of like of a neurocrystic or neuroectodermal origin, likely of neurocrystic or neuroectodermal origin. And we kind of mentioned there might be some potential for recurrence and metastasis. Just a few words about neurocrustic hamartoma. They kind of developmental lesion, usually on the scalp of young patients. Often they are congenital. Occasionally they can be acquired. They show very interesting histology. They're pretty rare, but then they show this kind of quite interesting histology, often 3 components. Some areas can look like a melanocytic lesions, like especially blue nevus-like area is commonly seen, neurosustandicular component, and mesenchymal fibrogenic elements. And they show exactly similar immunoprofile, often S100 CD34 positive. And these are some kind of example of cases, as you can see on the right side. Looks like a blue nevus. Here almost looks like a neurofibroma, and here is more kind of fibrogenic kind of growth. We don't really know much about molecular profile of neurocrustic hamartoma, and clinical behavior is a bit odd. They seems to be benign initially, but they can recur, and I think occasionally they can metastasize. So after that, I think 6 months later, we came across this paper describing a cohort of spindle cell neoplasm exclusively express CD34 and S100, and they showing recurrent kinase fusions, including RAF and NTRK and so forth. This lesion's been described often in children and adults in this cohort, and they tend to be more deep soft tissue. However, some of the cases were more superficial soft tissue and skin, and the clinical behavior was quite different from person to person. These are some kind of pictures from this study showing this kind of rather hypocellular spindle cell growth in the kind of upper part with this quite characteristic hyalinized fibrosis around blood vessels and in the stroma, and some of them looked like sarcomas, very cellular and kind of infiltrated with a lot of mitosis. Again, immunoprofile, some other kind of pictures from this study, and areas like almost like the FSP, this kind of infiltrative growth in the fat. There was another study by Chris Frecher and his group that they showed, again, they talked about the cohort of spindle cell lesions, again with kinase fusion and same immunoprofile. These lesions were more kind of superficially and more in kids and young kind of adults. And these lesions tends to show kind of a better clinical behavior, at least this study, and this is some kind of pictures from that study. And I think this is a kind of very recent publication by Prof. Miha and his group from Czech that they reported another lesion very similar to this one, I think very similar to our lesion, especially this almost meningothelial-like or interconnecting trabecular area, again with similar morphology. And in this case, they found a RET fusion. So this is expanding the type of kinase from RAF to NTRK and RET. So I think in summary, there is this evolving group of spindle cell neoplasm, often in young adults and children, and they show this kind of very specific immunoprofile. They have been reported at many different names, lipofibromatosis like infantile, but they probably spectrum of same type of lesions. In terms of our case, was more neurocrustic hamartoma like. The molecular profile we already discussed. Clinical behavior is quite variable in this lesion. And it's defined by morphology, at least at that stage. The ones that are very cellular and mitotically active, they can metastasize. And I think the first study I presented 3 patients from 16 patients, they died on follow-up. So they can be quite aggressive. I think the most important thing in this lesion to recognize them is because we have treatment available, some targeted therapy available, especially for those ones that kind of overt sarcomas, so we shouldn't really miss them. So my final remarks, so basically we know that the underpinning mechanism, molecular mechanism of neoplasm are evolving, so we are going towards a world with combining morphology with molecular for classification of the lesions, and molecular studies playing a very important role in diagnostics, prognostics, and therapeutics of melanocytic lesions. And I just need to thank some of my colleagues. I'm quite actually kind of lucky having very good colleagues in our department, having easy access to molecular studies. I know a lot of you guys, your hands are kind of closed because you don't really have, but it's a good opportunity for us. And thank you for paying attention.
Thank you very much. That was just a smashing presentation. I love it. It's, mind you, the thing that I've noticed is when I was training, things were benign or they were malignant. And if something metastasized, then it was malignant. And life was so easy in those days, you really didn't have to worry about it. But nowadays, metastasizing to lymph nodes doesn't really seem to mean anything necessarily. It might do or it might not. And the problem is you've shown us now, even at a molecular level, maybe it is, maybe it isn't. Now, what I wanted to ask you is, in dermatopathology, we've muddied our waters so much that we no longer know what malignancy really is anymore in a subgroup of patients. Are there the same parallels in other aspects of surgical pathology, or have they managed to make life easy still?
I think that's the same, exactly. In soft tissue, you know, it's just everything's a classification is changing, you know. Yes. With kind of knowing a lot of lesions that they've been reported as different entities, they're now all coming together on one entity. I mean, it doesn't really matter what you name them or how you classify them. I guess the important thing is to know their prognosis and how we're going to treat them. Because now, every day, there is a new therapy, new drugs, targeting one molecular aberration. And I must say, it's just like a kind of horrible market now because drug companies are just trying to make money. And sometimes they just find, the problem is a lot of molecular alterations that we find in this lesion, it's not relevant to the neoplastic progress of that lesion. They may be just by a standard mutation. So you need to really know which mutation, which changes are actually driving this lesion, you know, at. And then target that one rather than, you know, just finding a mutation and target that. I mean, yeah, that's the thing. I think it's changing in all over areas of, it's not just in melanocytic lesions.
Life is getting more difficult.
Oh yeah, definitely.
Well, unfortunately, I'm going to have to move us on because we've managed to get ourselves about 20 minutes behind, and the venison that they're cooking outside might get spoiled. So if you have any other questions, and I'm sure you do, this gentleman is free for a whole lunch hour. He doesn't need to eat. He'll answer all of your questions. And I think
there's just one more thing I wanted to say. I mean, I see a lot of pathologists are a bit scared of this molecular era coming and taking over their job. I think that's not going to happen. As far as we start to learn and kind of take that weapon, I think pathologists, they are the best people in terms of interpreting molecular results and doing them. The scientists, they have no clue at what they, I mean, all respect. I mean, they're very good at what they're doing and developing these techniques, but they don't know how to interpret that. Yes. And now we have, like, you know, blood biopsies coming, you know, just taking a sample from your blood and doing molecular testing. I think at the end of the day, you need to correlate with morphology. So rather than being kind of passive and scared and go back, we should learn. And they're not that difficult. I mean, it comes with time, you know. You need
I couldn't agree with you more. Couldn't agree with you. Thank you very, very much. So our last speaker of the morning is Elena Koshyk, and she's a graduate of the University of Donetsk, and she spent 10 years in an oncology situation, and now is a very respected member of the community. She's going to show us that subcutaneous fat is not just something we're trying to get rid of all the time because we're obese, but there's actually some really interesting things that can go on inside it. So with no further ado, the floor is yours. Thank you.
Good afternoon to everybody, and first of all, I would like to say that for me it's a big honor to be a part of such great event and stay on one stage with such amazing people. And as Professor McKee said, my topic today is cutaneous lipomatous neoplasm. First of all, First of all, I'd like to say about the new WHO classification of skin tumors. Such classification give us only seven entities of adipocytic tumor, but I would like to say that it's not only a 7. It's much more bigger adipocytic tumors which we can see in the skin. My first case from woman 63 years old with a painless thigh mass. It is a big mass. It was a big mass. It is a very common situation. It is a fatty mass with a big, thick fibrous septus, which contain a lot of hyperchromatic atypical cells. We can see also some cells, fatty cells with a hyperchromatic scalloped or intended nuclei, and I think everyone knows what it is. It is lipoblast. So it is also some pictures from that tumor, and it is a typical lipomatous tumor. It will be better to use the name of atypical lipomatous tumor for superficial lesion. If we have such lesion in for example in retroperitoneum, it will be better to use the term well-differentiated liposarcoma. It is a common tumor for adult people. It's deep. Often it's deep-seated, and the main location for that tumor is deep muscles of extremities. But it also be so big that we can see it, of course, in superficial parts of microscopic, it's a mixture of fatty cells and atypical stromal cells, and we have now we have 4 subtypes for that tumor. It's lipoma-like subtypes, sclerosing, inflammatory, and spindle cell subtypes, and the amount of lipoblasts will be variable, and it is a good example of inflammatory subtypes. It can be often in retroperitoneum, and as you can see, it is a mixture of foamy cell macrophages with very dense infiltrate, which consists of plasmocytes, neutrophils, lymphocytes, histiocytes, and we only can see some atypical cells. So it is a good example for next molecular testing, because all subtypes except sclerosing subtype have MDM overexpression by immuno and MDM amplification by molecular. It is diagnostic features of all subtypes of ALT, and of course we should to use molecular as much as possible, because it is such kind of tumors has very specific translocation, and we can use it. It is a tumor with a great recurrence rate, but distant metastasis never observed. I would like to say you that it is very important to slice such kind of tumors, use a lot of pieces of tissue, and use thin slides, because it is very important for excluding the areas of dedifferentiation. If we have areas of dedifferentiation, of course we use high recurrence rate and metastatic rate. the list of differential are huge. I show you only some of them, of some of entities. The first, my topic is lipoma with fat necrosis, with a lot of macrophages. Sometimes it can be very similar to lipoblast, and it is also a diagnostic pitfall because macrophages can be positive for MDM2. So you should remember it. Next, it's lipoma with Lochkern. What does it mean, Lochkern? It is from Germany. It is the nucleus, the hole in nucleus. When we saw lipocytes not in a lateral wall, lateral side, when we saw lipoblasts from anterior view, it can be very interesting. It can contain some hole in nucleus, so it will be also a pitfall. Fat atrophy. Fat atrophy we can see in people with malabsorption or starvation, and the main diagnostic clue for such a kind of lesion is lobulation and one size of all adipocytes, because liposarcoma has a variation in size and shapes of adipocytes. I'm sorry. Next is localized massive lymphedema. It's patients, usually it's obese patients or patient after lymphadenectomy. Such kind of lesion has fibrous derma, and we can see some lobulation with the fibrous septa in subcutaneous fat, and we can see just a little bit atypical fibroblasts. So you should, in such cases, you should use anamnesis of patient. It is very useful. Next, my cases, we have, with Tonya, we have some such cases. I think it's very modern because it is lip lesions. It is very interesting because it is lips of young women with a lot of cells that sometimes looking like a lipoblast. It is a typical, it has hyperchromatic nuclei, but I'm sorry, but all that cells are positive for CD68, and so it's macrophages. It is all that ladies after cosmetic procedures, so I think maybe in a few years we have a lot of such cases. Next differential is pleomorphic lipoma. It's I think I speak about pleomorphic. I will speak about pleomorphic lipoma just a little bit later. But pleomorphic lipoma sometimes has very atypical cells. It's also hyperchromatic, and it will be it can be a pitfall for lipoblast, but it is such kind of cells are not look like lipoblasts, that look like floret-like cells. My next case from a man 53 years old with painless posterior neck mass. It is not well-demarcated mass. It consists of adipocytes and some fibrous tissue, and this is we can see the thick collagen bundles and some blunt, just a little bit spindly cells with ovoid nuclei. This one, and just a little bit myxoid stroma. The diagnosis in such case, it's a spindle cell lipoma, and it is very typical for upper part of our body. So if you have a lesion with in a posterior neck, you should be first of all think about spindle cell lipoma. It is very, very often in such localization. Spindle cell lipoma consists of cytologically bland spindle cell proliferation plus variable amount of mature adipocytes and the fibromyxoid stroma contain brightly eosinophilic, coarse or ropey collagen fibers. It is a main diagnostic clue for such tumors. Amount of spindle cell component, it is extremely variable, and if we have only a scattered adipocytes, we call such lesions as cellular spindle cell lipoma. Myxoid stromal changes can be very prominent, and with the formation angiectoid spaces and with a very characteristic pseudoangiomatous growth pattern. And the one type of pleomorphic lipoma, or spindle cell lipoma, is pleomorphic lipoma, and except all features of spindle cell lipoma, it also contains bizarre cells, which has a very typical features. It is another variant of spindle cell lipoma with angiotoid spaces with a pseudoangiomatous pattern. You can see it closer. Next, it's a spindle cell lipoma with myxoid stroma and with positivity for CD34. Pleomorphic lipoma, it's another type. You can see collagen bundles. You can see the floret-like, typical floret-like cells. And by immuno, that type of lesions are strongly positive for CD32. And they are characterized by loss of 16 or 13 of material of 16 or 13 chromosome. It is completely benign lesions, so the complete surgical removal will be curative. The list of differential includes dermatofibrosarcoma protuberans, but such kind of tumors has more monotoles, and it infiltrates the subcutaneous tissue and arises a dermis of young people, about 30 years old. The spectrum of angiomyofibroblastoma, cellular angiofibroma, and mammary type myofibroblastoma, it's the main differential because it is also CD34 positive. It is also has the cells look like in a spindle cell lipoma. Sometimes probably that distinction lacks any clinical significance. Next is schwannoma and neurofibroma. It can be also CD34 positive, but such kind of tumor consists of wavy cells or buccal cells, and they strongly express S100 and SOX10. We can use it. Myxoid lipo, it's also in a differential. It has very characteristic plexiform vascular pattern and a specific alteration. And well differentiated lipo, it's also in differential. Myxoid lipo with a very characteristic, vascular pattern. Superficial cutaneous angiomyxoma, sometimes it also be in differential, but the cells angiomyxoma is more hyperchromatic, it's more spindly, and vascular pattern may be also helpful. Perinevrioma, for me it's also, I include in differential list such kind of tumors, but we can use the staining for EMA or staining for Claudine for excluding such kind of tumors. Next case from man, 29 years old, with multiple painful trunk and arms lesion. All his lesion was the same. And consist of major fat and a lot of capillary-sized vessels. Some vessels contain fibrin microthrombi. It will be better. Fibrin microthrombi, and our diagnosis. Our diagnosis was angiolipoma. It is very often multiple lesion for young patient. Microscopically, it's proliferation. It's a fat with capillary-sized vessels, and the main diagnostic clue for such type of lesion is fibrin microthrombi. The molecular finding, it's only one tumor from a list of adipocytic tumor which lacks any karyotypic alteration. It's completely benign tumor, and the main differential, of course, it's lipoma, it's intramuscular hemangioma, and Kaposi sarcoma. Sarcoma Kaposi, it's also multiple subcutaneous nodule in young man with a lot of slit-like vascular spaces, some spindle cells, extravasated erythrocytes, it lacks microthrombi, and it is consistently positive for herpes virus 8. Some example of intramuscular hemangioma. Next case, I'm so sorry, this is my previous presentation, so I think in that presentation we have no pictures of that tumors. It is man, 2 years old, with the penis thigh mass. We have no pictures, I'm so sorry. All that he has a lesion in a thigh, and the lesion consists of a lot of cells looking like lipoblast. It was multilobulated. It's a multilobulated lesion. It was which every lobules was divided into with fibrous septa, and lobules consist of adipocytes in different stages of their maturation, from very primitive mesenchymal cells to adipocytes. So it's a lipoblastoma, and sometimes sometimes it's very hard to diagnose such kind of tumor, and age of patient, of course, will be helpful. The main that tumors are positive for S100 and has a plaque rearrangement. It is completely benign, and the main differential entity for so that nosology is myxoid liposarcoma. It is completely another age of patient, because myxoid lipo is exceedingly rare under the age of 10, and it is less lobulated. It is focally we can saw some atypia, and we have a very specific translocation for myxoid lipo. Ordinary lipoma and hibernoma also can be in a differential. Hibernoma, it's a tumor which composed of predominantly brown fat. It is with a eosinophilic granular cytoplasm, and I think it is very, for me, it's one of simple tumors. Chondroid lipoma, it's another, it's not in differential with lipoblastoma, but I would like to speak about chondroid lipoma because I saw only 2 chondroid lipoma in my life. I don't know why, but it is a tumor with a predilection for women and with a predilection with extremities. It can be superficial or deep-seated, and microscopically it's variable admixture of mature adipocytes. I think we have no. It consists of variable admixture of mature adipocytes, eosinophilic chondroblast-like cells, and vacuolated cells in a myxochondroid background. It can be lobular. It can be well demarcated or ill-defined. It has a septus, and it consists of the cells look like lipoblasts and look like chondrocyte-like cells, and with a chondromyxoid background. It is another case. It is not good demarcated, but we saw a septus, and we saw all typical cells for chondroid lipoma. All that cells are S100 positive and have a specific translocation. It is completely benign neoplasm, and the differential diagnosis, you can see all that things except of soft tissue chondroma are malignant. So myxoid lipo, I'm sorry. Myxoid lipo consists of atypical spindle cells and delicate vascular pattern with a specific translocation. Extraskeletal myxoid chondro, it has also distinct globular appearance, but the cells more rounded and has eosinophilic cytoplasm. Soft tissue chondroma, it's a tumor with a predilection with hands and feet, and the main clue for me it's that such kind of tumors contain true hyaline cartilage. And myoepithelial tumors, they are often more superficially located. They displayed epithelioid areas, and by immuno, they express a lot of some of myoepithelial markers. It will be helpful. My next case, it's an old lady with a type-painless multinodular mass, and you can see the tumor, which has a low-grade component and high-grade component, with a very abrupt transition between 2 components. The high-grade component represents by spindle cell sarcoma, with a lot of atypical cells, with areas of necrosis, with mitotic figures, and low-grade areas. It it is well differentiated liposarcoma with the typical features. So the diagnosis in that case was the differentiated liposarcoma. It is sarcoma which consists of two components, well-differentiated lipo and another high-grade sarcoma with abrupt or gradual transition between two components. And the differentiated areas often look like as undifferentiated pleomorphic sarcoma or high-grade myxofibrosarcoma. Up to 10 cases of the differentiated lipo contain heterological differentiation. So we can see rhabdo, leo, osteochondrosarcomas or osteochondrosarcomatose areas. Sometimes high-grade component look like a low-grade component, not in well-differentiated lipo, like a low-grade sarcoma. It can be spindly. It can have not so many mitotic figures. And such cases, it is a cases with low liposarcoma with low-grade differentiation. It is also example of the differentiated areas with the MDM2 expression, and it is very helpful because such kind of tumors has a very specific alteration. It's amplification of MDM2 amplification with the MDM2 and CDK4 overexpression. It is high-grade sarcoma with a very big rate of recurrence and up to 20% metastatic rate. And distant metastasis can be most often can be in lung or liver. The treatment of such patient is surgical excision as wide as possible, but for surgeons it will be a big problem because well-differentiated component often look like a normal fat. And sometimes we received such material with only high-grade component. And so that is very important to understand it. And so the main differential is another sarcoma infiltrating fat. It will be useful to find well-differentiated lipo component or use MDM2 and for exclusion, use MDM2 amplification. Another entity is pleomorphic leiomyosarcoma. Of course, it have not a well-differentiated component, and if we so carefully, we can find a characteristic spindle cell pattern with a deep eosinophilic cytoplasm with cigar-shaped nuclei and so on. And maybe it is helpful to use immuno. And of course, sarcomatoid carcinoma. Sometimes we forgot about it. It can be, and it happened very often, so we should exclude, first of all, we should, for superficial location, we should exclude a sarcomatoid carcinoma, first of all. My next case from man, 54 years old, also with thigh mass. I think I like thigh. And this is a case with a well-demarcated tumor, but such tumor consists of a lot of bizarre cells, and if we try, it is really hard to find, but some cells look like a lipoblast. It is an example of pleomorphic liposarcoma, which can arise extremities, retroperitoneum, and so on, but it can also be as a superficial lesion. It is a disorderly growth pattern with high degree of cellular pleomorphism, include bizarre giant cells, and the most common pattern resembles undifferentiated pleomorphic sarcoma. The second pattern, it's a mixture of large pleomorphic cells and smaller mononuclear forms. But both of cell types are highly vacuolated and lipid-rich. And lipoblasts are easy to identify. And we also have an epithelioid variant. It's a small, round, clear cell predominant, and all cells look like the same. It's look like unio multivacuolar lipoblast. Immuno and genetic is not so helpful. We should try to find a lipoblast. It is a high-grade sarcoma with a big local recurrence and metastatic rate, and you can see that superficial lesions have excellent prognosis. It's not good for. It's not suitable for deep lesions such as retroperitoneum. The differential list include all pleomorphic sarcomas and melanoma, and of course carcinoma. And I have no last slide. It's missing, but it was a slide with take-home message. It was a slide that I would like to say that if you find the cell look like lipoblast, it is not the equivalent of diagnosis of liposarcoma, because a lot of cells can look like lipoblast. A lot of some benign lesions can contain lipoblast, and you should, if you find the cell look like lipoblast, you should interpret it in a histological context. Thank you very much.
Thank you very much indeed. That was smashing. I was going to ask you, sometimes with traumatic fat necrosis and sometimes with injected material, you can be not sure whether you're looking at a tumor or not. You can be very misled, particularly if it don't give you any clinical information. I don't know whether you come across that issue.
You know, I hear your presentation, and I think about that. I like your slide with that phone, because, you know, sometimes of course I use a clinical information, but sometimes I received samples without any information and without a possibility to connect with clinician. So it is difficult.
Yes.
It is really difficult.
Okay, well, thank you very much. I think we've managed to get ourselves quite far behind, so we'll stop now. And Vadim, you'll sound the alarm bell when we have to finish lunch and come back again, yes? Thank you very much. Thank you very much, Ellen. Thank you.
Thank you.